and you can keep your email open, okay, so that you are not delayed. We'll be sending the link soon. All participants, please come to the front. The link has been shared, but do not start unless and until we say, okay? Otherwise, your answers will not be considered. Please keep at least one seat gap. One seat gap. One seat gap. Okay, now that everyone is settled, we'll start. The links have been sent to your email address. You are supposed to be on this side. Then only maybe you will get the link. Recheck again.
It has been just resent. Please check your email. The mail what you have shared, it is sent to that mail only.
Refresh it, you will get it.
Anyone received?
Sir?
Hello.
Yes, sir. I know it.
Hello.
Can I send it to you? Please sit down. The links have been sent to your email address. Start answering. It has been resent, so I would suggest refresh it, because if many of you have received, there is no reason that some of you won't receive it. It's the same email address that you all have shared. Those who have received, please start. Sir, there could be network issues also. So according to Dr. Ravi, sir, this is the 25th IMM PG quiz. So you all are lucky to be in the Silver Jubilee year. So am I. I mean, because one of my mentor, Dr. Ravi, was the first quiz master. So I feel privileged that I'm able to do the same thing. But I don't know, sir, how good we will be able to do it. But we'll try our best. No new registrations. Sir, you are exempted. Sir, maybe, sir, the email is also seeing the age factor also, sir. Some of you who hadn't received, have you received? Who hasn't received? You have not received? Did you receive? Start. You can write her together.
Hello, 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 hello. Hello, hello. Hello, hello, hello. Hello, hello.
Anyone else is left? See, that is not something I can't let it. Invalid. Why is it saying invalid? Which one is invalid? Your Amul 4 Parikha. आप लोगों ने check किया आपको मिला या नहीं मिला? Because अगर मिल गया तो you are wasting time. हाँ? हाँ तो start. H नहीं है बाद में तो उसमें. हाँ? Resume. आपने check किया आपको मिला या नहीं मिला? हाँ बताओ. Jasmine ना? अच्छा Jasmine. Why are you so late? Huh? No, no. You have already registered. You must have got the email. You are not registered. No. For the quiz. Of course, it was announced yesterday. 3-4 times it was announced. Those who had given their names earlier, they must have received the email. Okay? So please start. Because it will shut down at a particular time. फोटो बॉम्बिंग ये सही बात नहीं है जगह ना
हाँ मुझे बताती हूँ
नेक्स्ट स्लाइड
हाँ
प्रीवियस स्लाइड इफ यू प्रेस
नहीं
एनी
प्रीवियस
ऑफ
स्लाइड नहीं चाहिए
हाँ नेक्स्ट
मुझे
स्लाइड
सो इसको बंद कर
Another 5 minutes. You won't be scored also, sir. 4 people answering 20 questions sitting together is. So we'll take the mean age, sir. And CV percent, sir? Yes, sir. So good, no, sir. If it is tough, then we'll have.
डिस्क्रिमिनेशन इंडेक्स अच्छा है. अरे माइक दे दिया. आज बात कर रहे हैं. नहीं, हम बात तो कर रहे हैं लेकिन नंबर नहीं दे रहे हैं ना.
दिस इज ऑटोमेशन. बात कर रहे तो माइक आ गया.
दिस इज
Time is over. So after this, no more answers will be considered.
इसको वो कर देना, सॉर्ट कर देना, सॉर्ट कर देना यहाँ से. हाँ, तो नेम से वो वाला कॉलम को सेलेक्ट करके सॉर्ट कर दो. नहीं, सॉर्ट ये गूगल शीट है क्या? हाँ, इसको डाउनलोड कर. इसको डाउनलोड खत्म हो गया ना, सब बंद कर दिया ना फॉर्म. Largest to smallest, sir. मैंने बोला टफ था पेपर. नहीं, 11 में बहुत सारे.
बजाना नहीं है. लाइन लगी है वहाँ. Good morning to everyone, those who have come late, and maybe a repeat good morning to others who had come earlier. So this being 25th year of IMM PG quiz, so instead of 2, we are being a bit generous and we'll have 3 candidates per team. Okay, so there will be 12 candidates who have been selected. We'll announce the name very soon. And then we'll form the teams also, and then they can come up and sit. Okay? So there will be 12 candidates. Sir, silver jubilee के हिसाब से हाँ, from down, sir. From down. ये लो मैम दैट इज फॉर स्कोरर एक इधर लगा
But you don't need more chairs, sir? Three. So who to get? Do you need only for the somebody?
So we are announcing the team. Team A, Dr. Aishwarya from Madras Medical College. And Dr. Preeti from GMC Nagpur. Dr. Kelvin from Maulana Azad. Okay. Team B, Dr. Mohammed from GMC. Yes, yes. And B is Polomi Viswas. And the third member is Dr. Dhirendra. Team C, the first member is Dr. Premnath. Second, Dr. DG. Third, Dr. Abhilasha. Team D, the first member, Dr. Hemant. Second, Dr. Neelina. And third, Dr. Arjun Banerjee. Neelina D. C.
और कौन रह गया टीम बी का कौन रह गया
Team B, Polomi.
पॉलोमी मोहम्मद
Dhirendra.
सुरेंद्र
Mohammed.
Team B, Mohammed. Full name. What is the full name? Full name. Mohammed Faraz. सर को चिंता है कि सर ने जो डिस्कस किए रॉन्ग आंसर्स वो उन्होंने कहीं सुन के चेंज ना कर दिया हो. Sir, you scored 20 out of 20. सफेद झूठ सर. मैम maximum marks was 20. Let's start. Good morning, everyone. Please settle down. Now we'll be starting the main quiz. Before we start, I would request the participants to introduce themselves, tell their name and from which college you are, and if possible, which year.
Good morning, everyone. I'm Dr. Kevin Joseph from Maulana Azad Medical College, final year.
Good morning, everyone. I'm Dr. Preeti Sharma from GMC Nagpur, Junior Resident 3.
I'm Dr. Aishwarya, final year postgraduate from Madras Medical College.
Good morning, everyone. I'm Dr. Paulomi Biswas from Grand Government Medical College, Mumbai, third year resident.
Good morning to everyone. Myself Dhirendra Kumar Pandey. I'm from Nair Hospital, GR3.
Good morning. I'm Dr. Mohammad Faraz Khan from Government Medical College, Suryapet.
Hello. I'm Dr. Premnath from AIMS Bhubaneswar, Junior Resident, third year.
Good morning. I'm Dr. Riji Slaser from Madras Medical College, final year postgraduate.
Good morning, everyone. I'm Dr. Abhilasha from Bangalore Medical College, final year postgraduate.
Good morning, everyone. I'm Dr. Nilina Suresh. I'm final year postgraduate from Bangalore Medical College.
Good morning, everyone. I'm Dr. Arjun Banerjee. I'm second year postgraduate in AIMS BB Nagar.
Good morning, everyone. I'm Dr. Hemant Saikia, final year postgraduate from Maulana Azad Medical College.
Thank you for the introduction. This is Team D, this is Team C, this is Team B, and this is Team A. Okay, please remember your teams because the questions will be asked accordingly. So, good morning to the 25th IMM PG quiz. Let me first tell you the rules. There are 4 rounds in all. Specific rules for every round will be told at the beginning of that particular round. Each team is advised to identify a spokesperson to avoid double answers. Otherwise, the answer which is heard first will be considered the final answer. Your time starts as soon as the question is read out. If you do not want to attempt a question, please say pass. Okay. Now, I think we got the introduction of all the participants, but I forgot to introduce myself and Dr. Sarita. stress or tension, whatever you can think of. I'm Dr. Sanjay Biswas, Head of Microbiology in Tata Memorial Hospital, Mumbai.
I'm Dr. Sarita Mahapatra. I'm additional professor in NAMES, New Delhi.
Okay.
So let us start the round one, which mainly targets the basic microbiology. I think all of you identified the spokesperson. Only one person will be telling the answer, right? Okay. So the rules for this round, the set A, it has two sets, set A and set B, which focuses on who I am. So the questions in this round rotate clockwise direction. So it will start from, I think, team D. Otherwise, we can go, the team name is there. It will be either A, B, C, D. We can go as that. Then the subsequent next team, it will pass on. So each question consists of two parts. Each team get 10 seconds for each part to answer. Correct answer to the first part will lead you to the second part. Each part gets you 10 marks. So correctly answering both the parts, you are fetching 20 marks. Incorrect answer to the first part will lead the entire question getting transferred to the next team. The next team to answer gets 5 marks per part. So a team has answering both the question is getting 10 marks, okay? And this, who has answered only the second part getting 5 marks. Only one pass is allowed. Do not answer out of turn. Further, the question passes to the audience and there are no negative marks in this round. I think all of you are clear. So the first question to team A. So my natural history was studied in the infamous Tuskegee experiment. John Wamphire declared against black. Who am I? And your timer starts. Very good. Can you say it loudly? Very. So the second part of this question, I worked on syphilis extensively and said the following: he who knows syphilis knows medicine. Who am I? Your timer starts. Time's up. Next team, team B. Audience?
Paul Ehrlich.
Yes. Who said William Osler? Very good. Can you tell your name, please? Dr. Basu. Okay. Many congratulations. So he is Sir William Osler, who studied the syphilis most extensively. It is not possible. It is not moving. Yeah, the second question, it is to team B. My outbreak was commemorated with the hand pump in 1854 in Broad Street. Who am I?
Vibrio cholerae.
Very good. So the second part of this question, I am single-handedly responsible for saving countless lives in children, the cholera epidemic in Bangladesh.
Dr. Mahalanobis.
Very good. Excellent. A big round. So full marks to team B. Team C. The question, my brother is endemic to India, but I am restricted to these areas. Who am I?
Talaromycosis, penicillium marnifer.
No. So team D, would you like to answer?
Scrub typhus.
No. Audience? Yes. A big round. It's Plasmodium knowledge. So more than 50% of Malaysian malarial are caused by Plasmodium knowledsae. Yes. Let us see the second part of this question. Can anybody answer this? I received the Nobel Prize for the medicine for my contribution in discovering malarial artemisinin combination therapy. Yes, sir. Sorry, sir. Oh, Shweta, great, great. A big round of applause. Good. The answer is to yo-yo. So question for team D. I was observed by Mahatma Gandhi. That moment was captured in this infamous photo. Who am I?
Mycobacterium tuberculosis.
Very close. Very close.
Lepri.
Very good. Yes, it's Mycobacterium lepri. So it's an easier question. The only animal that can contract Mycobacterium lepri and is implicated in...
Armadillo.
What is the band?
9-banded.
How many bands?
9-band.
9-banded armadillo. So full marks to team D. Good. So we have completed the set A question. Now the set B question, which is a video round. The questions in this round again rotate in clockwise. So team A will be the first one. Each team gets 10 seconds after the completion of the video to answer a direct question. Correct answer gets you 10 marks. There are no negative marks. It is a transferable round. Next team to answer gets 5 marks. There is only one pass allowed. Do not answer out of 10 and further question passes to the audience. So the first question, this is the video. So the question is, name the antibiotic that uses this mechanism to gain access into the cell. Team A, your time starts. Audience already know the answer. Time's up. Team B.
Ticarcillin?
No. Audience? Yes, it's cefiderocol, which acts with the Trojan horse mechanism. It's a cedar for cephalosporin. Okay. Your name, please? From? Ames Pune.
This was from the movie Troy.
So the next video to team B. So the question here is, give an example of false identification given by this equipment. You must have identified the equipment, I'm sure.
E. coli is sometimes misidentified as Shigella or Salmonella.
Very good, very good. So it's Malditov, which more or less misidentify E. coli and Shigella because of their closely related 16S rRNA. So for team C, the video. So the question here is, which parameter of the sterilization cycle does this test evaluate? Your time starts. Team C. Time's up.
Boetic test.
Sorry?
Boetic test temperature.
No, the test, it is which parameter it evaluate?
Temperature.
No. Team D?
Sports.
No.
Air
Anyone? Loud? Exact word? Air pockets. It ensures the complete air removal. Yes. So I think Parul will get, as well as Dr. Sweta again. Okay. So the next question to team D, the video, here it is. So the question here is, name the sequencing platform that uses this method
Illumina.
for application. Very good. A big round of applause. Correct answer. So we have finished the round 1. It is an audience question. Please name the person who won Nobel Prize in 2023 for medicine. Come on. Yes, what is the name? Anyone? One is yes. So the names are Catalino Carico and Drew Wiesman. These are the 2 persons who won for mRNA vaccine for COVID-19. So we can give her a chocolate, I think she answered. So now the score, you can announce the score after round 1.
Team A has total of 10 scores, 10. Team B has total of 30. Team C hasn't scored yet. And Team D has total of 30 after round 1.
We'll start with round 2. Please relax. मुस्कुराइए आप लखनऊ में हैं. That's what I can tell. This is round 2. This will be on clinical microbiology. The questions in this round will rotate in the anti-clockwise direction. That's it will start with D. 2 rounds, so each team gets 2 questions. You get 20 seconds to answer the question. This is a transferable round, so if one team cannot answer, it goes to the next team. Answer to the direct question fetches 10 marks. A past question fetches 5 marks. There are no negative marks. We'll start. Team D, question 1. Spot the diagnosis.
Rhinosporidium seabedi.
Sorry, it passes to the next team.
Visceral leishmaniasis.
Sorry, audience. Sir, you are not allowed to answer. answers?
Somebody answering. Yes, who is telling that? Stand up and tell your answer.
Correct answer. Now, it's the next question to Team C. The lesion developed after contact with a lamb being sacrificed. Next team.
Contagious pustular dermatitis.
Sorry, audience.
Which one? Which part?
Well, I'll give you a hint. This is a recent one.
So many.
So hint, because hint was given, nullified. Pardon, ma'am?
The structure is different for all.
Ma'am, the chocolate comes to us, ma'am. So it's monkeypox virus. Part 2. So this is for Team B. It's a subcutaneous lesion in a heart transplant patient. What is the diagnosis?
Sporotrichosis.
See the figure. I think it is visible there.
Yeah, yeah. Team A. Audience, your chance comes again. सर बाद में जो बचेगा ना सब आप लोग के लिए सर. No answers? Louder. Sir, your turn comes now, sir. Okay, so this is Majoci's granuloma caused by Trichophyton rubrum. Team A, your question, patient presents with high-grade fever and seizures. What is the diagnosis? Correct answer. Ma'am, it's severe falciparum malaria.
Please answer loudly while answering the order.
Now we go back to Team D. It's a 77-year-old male with history of hemochromatosis and liver cirrhosis, complaints of bilateral leg pain and lethargy, profoundly hypoxic and in shock, returning from a trip to the Atlantic coast a few days prior where they enjoyed hunting crabs on the beach and eating raw oysters. Shows profound leukocytosis, elevated lactate and creatinine. Blood culture quickly grows GNBs. What is the likely etiological agent?
Vibrio parahemolyticus.
You are close. It's not parahemolyticus.
You have time, you can change the species name.
Vulnificus.
Correct answer. Yeah, it's Vibrio vulnificus. Team C, 18-year-old male with a history of near drowning in a flooded roadside ditch, presented with respiratory failure, multiple brain abscesses. Labs show neutropenic leukocytosis, neutrophilic leukocytosis and elevated CRP, and serum beta-glucan. Lumbar puncture shows purulent CSF, which grows a mold with Y-shaped dichotomous branching septate hyphae. By day 3, the colony has taken on a tan color, and LPCB shows the following pictures. What do you think is the causative agent?
So Pseudosporium apiospermum.
Pardon?
Pseudosporium apiospermum.
Yeah, correct answer. Team B, 50-year-old male homeless living in an abandoned building, presents to ED with, casualty with fevers, chills, myalgias, and rash. He states that there were mice and rats in the abandoned building, that he gets multiple insect bites. However, he noted one of the bug bites got black and began to look like a cigarette burn. A few days later, he noted fever and chills with a sore throat. What is the condition and the causative organism? Team B.
Scrub typhus.
Read the history.
Anthrax. Anthrax.
It's in.
Is closer.
The question is passed to team A. What did you say?
Rocky Mountain spotted fever.
No, but so it's for the audience now. It looks like we will only enjoy the chocolates. Okay. The answer is rickettsial pox by Rickettsia acari. Team A, your question is a 53-year-old male, 8 days post-central line insertion, presents with fever, chills, and rigor. Gram stain of flagged blood culture shows gram-positive cocci in clusters, and rapid ID shows Staph aureus with MEC-A gene detected. The patient is started on intravenous vancomycin and cefepime. After 2 days, the patient remains febrile. Vancomycin trough level is 14 microgram per ml. Susceptibility testing of the MRSA isolate reveals a vancomycin MIC of 4 microgram per ml. It is susceptible to linezolid, daptomycin, and cotrimoxazole. What should be the line of treatment in this case and why?
Linezolid.
No.
Why and what is the treatment?
Vancomycin intermediate Staph aureus.
Be loud and confident in your answer.
Correct. They have given the correct answer. Yeah. It's Visa. Vancomycin intermediate Staph aureus, so we need to give linezolid. So,
One question for the audience.
yeah, this is the audience round. Your chance to win chocolates. Causative agent of fungal meningitis outbreak linked to 2 clinics in Matamoros, Mexico. Okay. The answer is Fusarium solani. Over. Score.
So after the second round, Team A has a total of 30 points, Team B has a total of 30 points, Team C 10, and Team D 40 points.
So the next round is your MCQ. And here the rules. Questions in this round rotate clockwise. 2 rounds. So each team will get 2 questions. Time for each question will be 10 seconds. Each question fetches you 10 marks. Wrong answer gets you negative -5. It is a non-transferable round. Further question passes to the audience. So the first question, an outbreak of an illness similar to dengue fever, characterized by fever, arthralgia, rash, and conjunctivitis, occurred in Yap Island of Micronesia in 2007. The virus came into prominence following this outbreak and was found to be an arbovirus transmitted by bite of the female Aedes mosquito. Which virus is belonged to? Toscana, La Crosse, Zika, and AC virus.
Zika virus.
Yes, it's Zika virus. Team B, which of the following is a category C bioterrorism agent? Bacillus anthracis, Ebola, Lassa fever, Nipah.
Ebola?
Wrong answer. So, audience? Nipah. Yes. So, it's -5 for Team B. Team C, hyaline molds that can produce culture with black overs and rivers are all except Schistosporium, Lematospora, Acrimonium, and Sporothrix.
Sporothrix.
Wrong answer. Yes. We can pass chocolate too. So it's Acrimonium. The next question to Team D. Man is the intermediate host for all except Plasmodium species, Wuchereria bancrofti, Toxoplasma gondii, and Echinococcus granulosus. It's Wuchereria bancrofti. I forgot to, yes, it's my apology. Okay. So the next question to Team A, which one of the following antifungal agent inhibits the de novo pyrimidine biosynthesis by preventing the catalytic activity of dihydrodehydrogenase? Orofilm, first manogepix, Ibrexafungerib, Risafungin.
Olorofim.
Yes, it's the correct answer, Orofilm. Team B, cutaneous larva migrans is caused by all except Ankylostoma brasiliensis, Ankylostoma caninum, Ancinaria stenocephala, and Toxocarina canis.
Toxocara canis?
Audience? It's the right answer actually. So, it's Toxocara canis, yes. This diffusion for Stenotrophomonas maltophilae is done for all the drugs except levoflox, ceftazidime, minocycline, and cotrimoxazole. Team C. Yes, correct answer. First row. The next question, which of the following drug was initially termed as Mississippi mud? Vancomycin, streptomycin, terbinafine, and caspofungin. Pass. Audience? Who told vancomycin? Raise your hand. Yes, it is the correct answer. It is vancomycin. So score?
So after round 3, Team A has a total of 50 points. Team B has a total of 20 points. Team C has 5 points and Team D has 40 points.
So big round for
Team A.
So we have the last round, I think rapid round.
This was marks.
It has negative marks. Yeah, because both the answers. Both the answers you wrong.
You both answers.
And total second questions and both the answers were wrong. So -5, -5. The second one, Toxocara is right. Okay. So 25 points.
There is a correction in the score. Team B is with 25. Correct? Score.
Okay. So the final scores are Team A has 50 points, Team B has 25 points, Team C 5 points, and Team D is 40 points.
Okay, so for Team B, Team C, Team D, all the best. Buck up, come to Team A level. Okay, give them a good fight. So this is a rapid fire round. I'll be firing 10 questions within 1 minute. You have to answer. This is a non-transferable round starting with Team D. Each team gets 1 minute to answer 10 questions. Each question carries 10 marks. Each team is advised to identify a spokesperson to avoid double answers. The answer which is heard first will be considered as the final answer. If you do not want to attempt a question, please say pass. This question can be taken up later by your team if time permits. Okay? So Team D, please identify who will be answering. Team C? Team B? Team A? Team A, who will be answering? So we start. Klebsiella bacillus is?
Pass.
Intranuclear inclusion bodies seen in herpes virus infected cell?
Pass.
Jerky motility is seen in?
Trichomonas.
Broken slide is discarded in?
Blue container.
Correct. Modified macrophage present in placenta called as?
Pass.
Darling disease is caused by?
Histoplasmosis.
Correct. Mycobacterium gordinae is a photochromatogen. True or false?
True.
Wrong. Most common cause of viral diarrhea in adults?
Adenovirus.
Wrong. Number of air exchanges recommended per hour for high risk areas?
12.
So we'll consider this answer because you have answered it at dot. So
What do you have answered? Please repeat your
12,
answer.
12,
Last answer.
12 hour.
12?
Yeah, correct. So how many correct for them?
4.
4 correct and wrong?
Rest pass. Rest are wrong. Rest
Correct.
are pass. No, 1 wrong and 4 correct.
Okay, so you have got 4 correct answers. Sorry, these are the answers. I don't need to. Okay. So Team C, Paphos bacillus is?
Haemophilus influenzae.
Correct. Intracytoplasmic inclusion bodies seen in molluscum contagiosum virus infected cell.
Pass.
Darting motility is seen in?
Vibrio cholerae.
Soiled gloves is discarded in?
Red.
Modified macrophage present in the brain called as?
Microglial cells.
Okay. All the 3 questions were correct. Desert rheumatism is caused by?
Paracoccidiosis.
Wrong. Scrub typhus is transmitted by trombiculate mite. True or false?
True.
Correct. Mycoplasma colonies can be stained by which dye?
Dynes, no.
Correct. As per CDC, the percentage of hypochlorite to be used for small spills should be less than or equal to 10 centimeter.
1.
Okay. So your time is over. 6 answers correct. These are the answers. Oh. So it's team B. Whitmore's bacillus is
Burkholderia pseudomallei.
correct. Cell line used for the isolation of influenza virus?
MRC5 cell lines.
Wrong. Tumbling motility seen
Listeria
in?
monocytogenes.
Correct. Laboratory culture plates are discarded in?
Red bin.
Wrong. Modified macrophage present in
Kupffer
liver?
cells.
Correct. Chiclero ulcer is caused by?
Leishmania.
Correct. Loa loa has sheathed microfilaria with 2 nuclei at the tail tip. True or false?
True.
Wrong. Todd-Hewitt broth is used for which
Group B
group of-
streptococci.
Okay. Type of biosafety cabinet with no recirculation of air and 100%.
Type 3.
Pardon?
Type 3.
Wrong. Gene responsible for rifampicin resistance?
RPOB gene.
Correct. So you have 7 correct answers. So this is for?
Actually, team D. Team A has answered the team
Okay.
D.
Okay, so
We'll just switching over.
I goofed. I think this is for team D. Team A. No. No, team D has answered. Okay, so sorry, this is for team A. Eaton's agent is?
Mycoplasma.
Correct. Strain used in yellow fever vaccine?
17D.
Correct. Falling leaf motility seen in?
Giardia.
Correct. Vaccine vials are discarded in?
Blue.
Wrong. Modified macrophage present in connective tissues is called as?
Pass.
Buruli ulcer is caused by?
Mycobacterium ulcerans.
Correct. Hymenolipus nana is known as dwarf tapeworm. True or false?
False.
Wrong. Name one enterovirus causing acute hemorrhagic conjunctivitis.
71.
What 71?
Enterovirus 71.
Enterovirus?
Pass.
Minimum duration required to sterilize the laparoscope by 2% glutaraldehyde.
Pass.
Media used for antifungal broth microdilution.
RPMI.
Okay, we'll consider this answer. Correct answer. These are the answers. So you have 5 correct answers. So this is the end of the IMM PG quiz. Oh. अब क्या करें? Tie breaker. There are 2 teams who have same score. Team A with 100 points and Team B with 100 points. Yes, sir.
The first IIM quiz in 1998 ended in a tie.
Oh, so there are we have
So we have 2 questions for tiebreaker. One will be asked to team A, and if it is not answered, if you are answering, then you will be given marks, 10 marks. If you are not answering, there is no score. The second question will be for team B. Okay?
as per the suggestion of Dr. Vimala Venkatesh, and we have to accept that, we will give prize to both the teams. This being 25th year, so sir, we will have a special consideration. Thank you, sir. On behalf of me and Dr. Sarita, I would like to thank Dr. Kavipriya, JR from AIMS, New Delhi, for helping us to prepare this quiz and the presentation. Thank you, Dr. Kavipriya. Prizes will be given during the valedictory function. Okay? Is that fine? Yes. So you'll have to stay. Yes, sir. Because we want you all to stay. I mean, thank you everyone.
Your prizes will be given during valedictory.
I hope you enjoyed.
Whoever is missing, I will take the medal home.
सब एक साथ खड़े हो जाओ, फोटो लेना।
So we break for a rapid fire tea for 5 minutes only. Just grab your tea and come back. So 10 minutes. So 10 we reconvene. So we are running short by 10 minutes. And then we begin with IMM Symposium. हाँ ये तब तक चाय पी के आएंगे तब तक आ जाएगा। Dr. Aarti ma'am, to felicitate our moderators for the quiz masters. एडिट करने में ना, हाँ मुझे लग रहा था कि यही लोग करते हैं। क्यों चल रहा है अभी से? हाँ 1 मिनट। Dr. Sanjay Biswas, thank you so much for mastering this quiz master. And Dr. Sarita. Thank you, Sarita. Poonam and myself have been doing it for 3 years. और हमें ना हमेशा होता है कि जब तू से प्रतिभा लगी ना मुझे निकाल दियो इसमें से। She's our lady chapter का quiz master also. वो ना 10 years. उसने 1 साल वो भी छोड़ दिया। हाँ हम ज़्यादा मजे कर रहे थे। अरे मेरा नहीं होता है। मैं भी तुम्हारे।
We forgot Dr. Sonal Saxena.
मैंने
मैम आपके साथ
This is just to inform that there's a small tea break, after which we will then conduct with the another session, which is the IM Symposium on the Clinical Microbiology at the Crossroads, Genomics to Precision Medicine. So we would request the honorable delegates and the faculty to please break for this tea, and we would request you to please gather in the hall. We will try to ensure that. Humble request to please come back as soon as earliest. Thank you so much, all of you.
बच्चे तभी तो हम बाद में क्विज दे नहीं देते सबको जी जी आए जा रहे हैं आए जा रहे हैं आए जा रहे हैं 9 बजे आ रहे हैं किससे मैम तुमने वो लाइटिंग क्यों करा दी मैंने नहीं कराई वहाँ पे किसने कराई हमें हम वहाँ पे जाके हम लोग बोलना है हमने क्या हम तो हमसे ऑकवर्ड का क्या मतलब है लाइटिंग तो किसका आइडिया था ये मैम वो उन लोगों ने खुद ही करा दिया हाँ और हमने कहा हमने बताया कि नहीं हम लोगों को हमको बोलना भी कुछ था गणेश वंदना चला के कोई दारू हाँ वो हमें मुझे डॉक्टर चक्रवर्ती ने तो क्रॉस मीटिंग नहीं मैम एक्चुअली हमें का तो हमें बताते तो कम से कम वो जो उनका पीयूसीटी वाला बंदा था ना उसका ब्रेन चाइल्ड हुआ अच्छा मैंने कहा कि कम से कम सब हम सबके साथ फोटो खिंच जाए नहीं मैम हमने कहा भैया हमें बताते हमें कुछ बोलना हमें तो पता ही नहीं है कि हमें कुछ बोलना भी है नहीं बोलना ठीक है वो दैट इज ओके लैंप लाइटिंग अंदर बंदना नहीं होनी चाहिए थी क्योंकि वो बेसिकली तो सब मुर्गा खा रहे दारू पी रहे हैं यार और किसी और ने भी मेरे को बोला कि तुम्हारे नॉर्थ में ऐसे होता है मैंने तो सबको ये कहा कि स्पॉन्सरर की डिमांड होगी अगर कोई पूछे तो स्टिक टू दैट जी जी अच्छा ठीक है इट्स इजी वे टू गेट आउट है सबको पता है स्पॉन्सर के बिना
me a slide for you. Then you, if it doesn't go forward, just click on this.
इस पे ना?
हाँ इस पे
नॉर्मल लाके टैप वो मैंने कल यही किया था कल भी ऐसे ही शाम को नहीं चला तो मैंने इसी पे टैप किया था इसको मैंने नहीं ठीक है अब तो चल जाएगा नॉर्मल हैंड हेल्ड माइक दे देना कोई दिक्कत नहीं
साची टीवी उठवा लो दो बंदे टीवी उठवा लो साइड में
हेलो 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 हेलो
स्टेज मैनेजमेंट टीम इज डिफरेंट आई हेल्प यू आउट
नहीं बेटा मत कर रहने दे वो एवी वाला है मैं तो हेड ऑफ द डिपार्टमेंट हूँ 15 साल पढ़ाई करी है बेटा
पूरा मैं बहुत सारी
अरे कहीं गिर गया होगा इसको चालू करवा बेटा Good morning, everybody. Can I request the Honorable President, Dr. Aarti Kapil, to please come and chair the IMM Symposium? I would now request the moderator of the symposium, Professor Pallab Ray, former HOD, Postgraduate Institute of Medical Education and Research, Chandigarh, to please come and moderate the session. The topic is Clinical Microbiology at Crossroads, Genomics to Precision Medicine. Hurry up and settle down fast, everybody. It's a very interesting topic.
Hello. Good morning, everybody. I think most of the people, they have already started coming in. Now we are going to start the IAMM Symposium. The topic is Clinical Microbiology at Crossroads, from Genomics to Precision Medicine. If you look at it, in the last 2 decades or so, there has been immense developments in molecular technologies, and which have really taken us to a totally new level in understanding microbes, in understanding the host, in understanding the environment. And this is gradually affecting the management of most of the diseases. If we look at every health and disease, they are actually the outcomes of, we know that the agent, the host, and the environment. And we cannot really put any of the 3 components under a blanket term. We know that bacterial infections, viral, fungal, parasitic, they behave differently. If we look at even within the bacterium, each species has got its own distinctive way of interacting with the host. Even if I take one species, Klebsiella pneumoniae, the different strains, they behave differently. And even within the strains, there are other differences which give them uniqueness of their properties to interact with the host. If you again look at the host, and truly speaking, what I was telling, there lies the importance of taxonomy, because simply knowing which organism is causing an infection tells us many of the things. So now we have gone beyond simple species to other molecular characters of different organisms. Coming to the host, if we look at the host, the same strain of organism, when interacts with different individuals in a population, they result in different types of manifestations. We have seen that in COVID-19 outbreak. The manifestations could be anywhere between subclinical colonization to serious disease, causing even morbidity or mortality. That shows that the differences in the host, they constitute a very important aspect of the result of interaction between the microbe of the host. Now, if we go into the environment, again, there are multiple environmental factors which decide what will be the outcome. So ultimately, we are thinking about precision medicine, which exploits the understandings of the properties of agent, host, environment at a very molecular level, and to exploit the same in our understanding, diagnostics, management, prognosis, and prevention of different disease processes. It has already started becoming a very important component of medical sciences, and it has started invading even into the microbiologic aspects. Now, we cannot really go into all aspects of prospective role of precision medicine in microbiology. So we have 3 speakers who will be dealing with precision medicine prospects in virological diseases, in bacterial diseases, and in mycobacterial diseases. My apologies, we won't be discussing too much on fungal diseases or parasitic diseases today, which probably will come up in some subsequent sessions. So out of the 3 speakers, the first speaker is Dr. Ekta Gupta. Right. Dr. Ekta Gupta is the professor of and head Department of Clinical Virology, ILBS, New Delhi. She specializes in virology, transplant, hepatic, respiratory virology. She has more than 24 years of experience in clinical diagnostic virology, and she has more than 130 scientific publications indexed. She has to her credit several extramural research grants. She is the nodal officer for WHO CC at ILBS for viral hepatitis, and she is in charge of COVID-19 testing laboratory and genome sequencing lab for Delhi state government and INSACOG. So I invite Dr. Ekta for her presentation. We are planning to limit each presentation to around half an hour so that we can have some time at the end of the session to interact with the audience and share their views on the same topic.
Pointer.
Dr. Ekta, please.
Yeah. So, very good morning, and respected chairperson and moderator, sir, and the seniors in the audience. It was a difficult topic. I think I'll try to explain my perspective from the virology. So, genomics to precision medicine, virology at crossroads. So I'll be covering the topic in these 30 minutes under these headings: conventional virology, what was lacking, what was the need to upgrade serological testing in virology, need to upgrade molecular testing, changing new face, point of care molecular test in virology, then beyond DNA RNA, that is multi-omics, genomics for antivirals and resistance testing, host profiling, which matters very much in the viral diseases, virus-associated carcinogenesis, human virome, and then in the end, are we at a crossroads and what we should do for these crossroads. So just a brief overview for those who have just joined the MD. Diagnostic methods in virology traditionally are where you detect the virus, either direct or indirect methods of identification. Direct, which were culture, electron microscopy, or staining for inclusion bodies or their direct effects were there. Indirect, when we look for the antigen antibody responses and the DNA, RNA, and the nucleic acid test in the virology. So the crossroad starts. Because the conventional methods we had of the culture, microscopy, serology, and the earlier methods of the heme agglutination, HA, CFT, agglutination-based ELISAs, and even I have included in conventional methods ELISAs, was not diagnosing enough of the viruses that were available. So anything with the unknown etiology was labeled as a viral. So nothing, if in your algorithm cannot make it out, make it as a viral. So what was the limitation? They were slow, the limited panels were there, precision and personalized approaches to medicine, taking care of the clinical care of the patient was not possible with these. So the crossroad, the second road which came in front of us was of this beautiful era of genomics and virology. Real-time PCRs in the last decade have taken over the complete set of diagnostic virology. The other brothers of this real-time PCRs which are coming are the multi-omics, microRNAs, host responses, and viromes. The advantages are and disadvantages are that they are very expensive, but yes, precision reporting is possible. Apart from the diagnostic, you can have many more aspects, but the quality needs to be checked in. All these behave garbage in, garbage out. You put in garbage, the garbage will get amplified and will be out for your this thing. So this I have already said, that conventional virology was lacking in being time consuming, labor intensive, sensitivity was limited, multiplexing was very, very difficult, and difficult to perform, although they were very, very cost effective. If they were pathogen specific, then they were specific also. So we needed the upgradation of all the viral serological labs, because you want to be doing precision testing. We are not going to delay the report. So the effective clinical sample reporting by reducing the turnaround time of reporting in viral serology was a main thing to look forward, and this is the thing in the last couple of years have become very, very fast. Batch testing concept needs to be avoided, because if 96 well ELISA plate is not complete, or 24 samples or 8 samples with the controls are not put, so we are trying to avoid the batch testing concept. We are moving towards development of more sensitive as well as specific, and identify specific antigens, not the cross-reactive or broad antigens which the agglutinations or those assays were targeting. And we are also looking at moving towards changing the generations of the serological test by reducing the window period. So you have all these technologies and instruments which are coming up. I'll just start giving you because the precision, so once this upgradation started, the specific serology testing with reduced stat has come up. This is one case scenario from my institute. A 34-year male having a CLD alcohol related reaches emergency with features of acute liver failure, totally decompensated cirrhotic, ascitic hepatic encephalopathy. So what we do, we have panel testing for the acute liver insult, the bacterial A to E viral causes and drug-related liver injury all were ruled out. And then we have non-hepatotropic viral panel, which includes all the non-hepatotropic insulting viruses. And immediately, within few hours, the HSV IgM was positive. We subsequently did HSV1 from the plasma and DNA was detected. Immediately it was reported, patient was started on a very good antiviral acyclovir. The liver failure could be reverted. So this is the, it's not moving. Yeah, so this is herpes virus-related hepatitis, very, very rare to cause acute liver failure, but faster serology testing and specific antiviral medication could save the lives, in which we see this is the changing scenario. Another one of the precision testing, we reported it also, is the Epstein-Barr virus-associated hepatitis, again, because now the markers which are very, very specific, not so cross-reactive to the other herpes viruses available. So these are the two case reports which we reported, we identified. We also did the EBV DNA, and we referred to the gastroenterologist. Though in this setting, no specific antivirals could be started. But how this helped, you very fastly, you pinpointed the diagnosis, which prevented the further list of the investigations a gastroenterologist would have ordered. And so this is again precision medicine, where etiological identification at a very initial stage will will help the patient better management and economic benefit to the patient for unnecessary futile approaches. So this is one, how the upgradation of serology and faster serology reporting is really helping out at the bedside to the patient. We really needed to upgrade the molecular test because we want faster, specific, sensitive PCRs, I say, which are easy to perform. You really do not require those huge area 1, 2, 3, 4 specified labs. You want multiplex targets. Syndrome-based testing, combining all these targets in syndrome-based is, we've had seminars, should be there. Again, avoid batch testing. Now the random access platforms which are easy to handle, where each sample can be, and and you can access the random sample. So you can have multiple targets and the multiple tubes going in, and you really want all these molecular assays to be quantitative, although qualitative are still in, but quantitative is better for the patient management and precision. So there are a lot of point-of-care devices by a lot of companies which have come up in the last decade. I'm not going to name them, but they are based on very, very highly sensitive spectroscopy-based approach, electrochemical biosensor or fluorescence biosensor approaches, so which increases the specificity and reduces the turnaround time for point-of-care of devices. So gone are the days in the molecular testing labs where you require these 4 areas, area 1, 2, 3, and trained manpower with the turnaround time for the reports to be 5 to 7 days. And again, depends upon your workload. If your workload is less, then you will keep the TAT for a molecular test would be around a week or so. And centralized labs where the molecular testing can be done. So you require these point-of-care benchtop devices available so that minimally trained manpower can handle. And the molecular testing can be decentralized to the periphery where the treatment and the patient actually can afford to come. So this is another example which I show that we did in the state of Delhi for hepatitis C control, the decentralized method of the Head Start project with WHO and FIND. And here we actually decentralized the molecular testing for HCV at the Mohalla clinic levels in Delhi. We targeted 15 Mohalla clinics, 5 major hospitals, and ILBS as the central in a hub and spoke manner. And how effectively we could screen 38,000 for hepatitis C patients all across Delhi with an RNA detection. 91% they were tested. We could give them treatment, and the patient's average visit to the healthcare facility was significantly reduced to 2.4 day visits to the healthcare facility. So when you have these point-of-care devices, you decentralize them into the periphery. This is the effect of these changing technology can have in the public health sector also. Now, multi-omics in virology. So we are, in the molecular testing, we are moving beyond DNA and RNA. So how they are helping, this is a screenshot that you can do genomics, you can identify DNA, RNA, you can utilize it for testing, you can utilize it for understanding a virus, identification, vaccine preparation, therapeutics. You can identify the proteomics, and they can help you in formation of the biomarkers, immune pathways understanding, and that helps in the pathological mechanism diagnosis and prognosis. You can identify with the machine learning and bioinformatics the entire cellular components which are involved so that you can fine-tune your therapeutic targets and this thing. So this is the new phase of molecular testing in virology, moving beyond DNA and RNA. COVID, everybody knows, I'm not going to touch, but just a screenshot of a very good review article which is concise that how these omics, proteomics, multiomics, single cell multiomics, and have actually translated to the finding and precision medicine. Just one example I'll give is that, like in proteomics, the cathepsin L1 was significantly upregulated in the COVID-19 lung. And so this came up as a very good marker for understanding or diagnosing the severity of the lung infection. So these were a lot of meta-analysis or a lot of review articles are available where COVID has really taken a lot of help in control of this COVID infection, not only in individual but in the society, based on all these multi-omics approaches. We also did a study and got it published where we tried to find out the biomarker, and in this study we found, based on the proteomic approach, MX1 and VORS, which is a tryptophan tRNA ligase, could be utilized for early identification that which patient will land up into severe illness and which will not have a severe illness. And this was just a markers. We were trying to finalize the more prognostic studies, but this marker has also already been utilized in many respiratory viral infections. Now this is MXA is a very important promising, which is we have found it from proteomics, which can actually in the critical care ICU distinguish a viral etiology from a bacterial or a fungal etiology. So if you're waiting for a culture report to come or for a biofire report to come, these markers can be utilized in the critical care setting. At least the escalation of antibiotic and AMR, and you can prevent exposure to high-ended antibiotic if a viral etiology at a very initial level based on these biomarkers. So people are now using these biomarkers. Another area where genomics have really helped is the development of antivirals, drugs and treatment for viruses. Till now, the treatment was only available for HIV, B, C, influenza, and herpes group of viruses. So there are whole huge range of viral infections and diseases which are available, which require specific antiviral. So genomics, you can actually identify the novel targets. Drugs can be repurposed. One beautiful example is the antivirals which are used for hepatitis C are nowadays being repurposed for hepatitis E infection. The sofosbuvir people have tried, and it has come up with very nicely for HIV, in chronic HIV infection. Resistance testing for these antivirals has always been very, very helpful in personalized medicine, because you can change the course of the treatment, change the treatment line. One good example of how one viral infection has been affected by a modified conventional method, I'll call. So HCV is a very new virus, only in 1989. We know the Nobel Prize last year also went to the person who discovered this. This is a virus which was difficult to grow. But how the genomics have helped is that instead of growing the whole virus, the replicon system of the HCV was created in the year around 2008 and 9, because before that, PEG interferon was the only treatment available, which was not giving a good response, and we were difficult to grow the virus. The changes in the replicon system, you don't grow the entire virus, you take the subgenomic regions of the virus and you transfect them into the cell. So the whole face of hepatitis C control was totally changed. The direct acting antivirals came, and look at now, the WHO is aiming for eradication of hepatitis C by 2030. So it's none other infection which has gained so much. And the current direct acting antiviral therapy is 97 to 98% effective. Drug resistance, hang ho jata. So precision medicine and antiviral resistance. So the antivirals are there, but then the role of genomic comes in identification of mutations so that you can offer a personalized. So these are generic drugs, pangenotypic, the program or under the program they always say use them. But when we are dealing one-to-one scenario, then you really have to take care of each patient on its own. Another example from our institute, this is a 56-year-old female. She had HCV infection. She was non-cirrhotic. As per the guidelines, WHO, all very simple to treat, 97% by DA should treat. But she was tried on so many regimes, interferon, riba, failed, soft DAC, failed, soft Velpa failed, and finally when the drug resistance testing was done, we found that she had significant mutations in the NS5A and NS5B region. So a newer NS3 inhibitor was started, HCC monitoring started, patient stabilized and improved. So this example says that you can have blanket antivirals, still case-to-case variation occurs. Precision medicine is needed because viral infections are mostly controlled by the host immune responses. And these host immune responses, they influence the virus clearance, and that is why you have to follow each and every patient and do precision medicine. Another good example of how the host immune responses are controlling is the HBV, the new phase of hepatitis B virus control. So currently the treatment targets only the DNA, and you have HBV DNA negativity as the virological response. But the studies have shown that it is the HBsAg which is actually killing your immune response. So even your CD4, CD8 based CTL responses are not there because of the highly persistent HBsAg. So with the help of the genomics, the newer targets for hepatitis B cure is coming up, that we are trying to have inhibit either the secretion of HbA/Ag from the hepatocyte into circulation, or you are trying to build up the lost immunity through the new generation hepatitis B vaccines which are coming, which are more therapeutic vaccine. So we are not only targeting the prevention or stopping the DNA, now we want the host immune responses also to rise for hepatitis B cure. So this is another example how the control of a disease is being controlled by the genomic approaches. Host profiling for viral diseases, this is a new kid in the block. Everybody is talking about how the mRNA, microRNAs are being used in the personalized medicine. So there are a lot of infections, results in spectrum of disease severity. These circulating microRNA signatures may differentiate between, ultimate disease outcome. Example is the liver-enriched microRNA MIR122. A lot of information is coming out that despite a very efficacious HCV therapy, the efficacy or the SVR attainment, a lot depends upon the host response to the therapy. So this is another biomarker by which you can personalize the treatment responses in viruses. Virus-associated carcinogenesis have also gained a lot of importance in the last few years because the cancer arises from the accumulation of genetic and epigenetic alterations which are happening, and tumor viruses can insert these mutagenesis. They can upregulate so many oncogenes. So the vaccination prevention of these viral infections in a way controlling the carcinogenesis, and you are actually finding out the targets to which are the oncogene development, like HBX gene in the hepatitis B has an oncogenic potential. So rather than, you can control, but you can also silence that gene proportion which has an oncogenic potential. So this is how, even in the cancer control, the genomics and knowing the regions in the virus by which you can target and control these infections. Lastly, human virome analysis. This is a huge new era because people are done with the, I think, bacteriome and fungome, and so now the virome. So the human body hosts lots of microbial community inside, and these are known as microbiome. So the human body also has got a lot of viruses which are virome. These are basically the eukaryotic viruses and the phages which are there, and the whole information is coming through the machine learning devices and understanding these viromes to, in decision making, especially in the gut, like what will be the outcome of the liver diseases and gut diseases, cirrhotic versus non-cirrhotic. Is the microbiome or bacteriome understanding is good enough, or the virome understanding? So this is a huge era where in the human virome distribution has been completely thought of, what all which are present in what all sites, and how all the researchers is moving towards identifying how they are influencing the ultimate disease response. Ultimately, the precision medicine cannot be to the patient, it has to go to the public health. So precision medicine lab has to go to the public health. We have seen in the COVID that how the data collected from individualized patients has helped in formation of surveillance strategy, development of antivirals, vaccines, guidelines, and preventive strategies. So ultimately, the outbreaks and surveillance strategies all can be formulated if we keep on giving the data and understanding the each at the level of the personal medicine. These can help with the precision medicine. Viral genomics, but again, a world of caution. You have to practice with lots of caution. Cost effectiveness have to be well weighted. It cannot be that any test available, start ordering. Validation and quality check for the data is extremely, I told you, important, because garbage in, garbage out. Host-to-host variations have to be assessed, which is difficult because how will you understand in a diagnostic this thing that you have to take very careful history. All genomic results might not indicate an active ongoing infection, especially with the colonizers. One has to be very, very careful, and you should correlate with if the gold standard is available, so that the colonizers are not reported like this. So in the end, I don't think so we are at the crossroads. We can merge the two crossroads by taking best of everything. We can update our conventional system, make them faster. We can carefully report with the genomic assays and start doing more of the precision and personalized reporting. So we are at a crossroads, but I think the future is merge these roads and take best of the knowledge possible from both the systems and go ahead. Thank you, sir.
Thank you very much, Dr. Ekta, for an excellent presentation. We will have interactions with the speakers and the audience at the end of the presentations. So I now invite Dr. Sumit Rai, who is Professor and Head Department of Clinical Microbiology, AIIMS Mangalagiri. He has special interest in antimicrobials, antimicrobial stewardship, and everything around that. He is a gold medalist in MD and has won IAMM Best Paper Awards in bacteriology twice, more than 50 publications and 5 projects under his control. And personally, I know Dr. Sumit. He is one of the professor and heads I know who prefers to have a test tube on his left hand and a micropipette on his right hand and work at odd hours in the laboratory rather than simply doing office work. So Dr. Sumit will talk about precision medicine in bacteriology.
Thank you so much, sir, for the kind words. Before I start, this disclaimer is that I am a minion among the August gathering of such senior teachers of teachers. Dr. Anlok is there, Ravi sir is there, and of course, 2 senior bacteriologists I've always looked upon, Aarti ma'am and Pallab sir. Before I introduce, sir has already introduced me, and I'm very thankful for this kind word, sir. I'd like to introduce my institute also, because it's a new institute that most of the people don't know about. And the way that we have always confused to call pneumocystis gyroesi, it's Ero with Z. So it's not Mangalagiri, it's Mangalgiri. So Mangalgiri means it's the auspicious hills. Mangal is auspicious, Giri is hills. So we are located, as you can see, right between these 2 hills, which is guarded by Lord Narsingh Bhagwan. And we are, you can say the department is around 3 years old. I'll be nearly joining 2 years just before it's happened to me. I joined the institute. So before, like we have been, ma'am is from ILBS, it's a very high-end institute. And let us come down from our thrones, from our glory, and get back to the real story, what is happening in the government medical colleges over here. So let's see, when we are not practicing diagnostic stewardship, what really happens. So what happens, because this is the 6th institute I'm working. I've worked in 6 different institutes, and all government institutes, so I'm fairly aware of what really goes on at the ground level. So let's talk about, let's introspect and look at the mirror first, what's happening before we talk about the omics. Okay, so it's a government medical college, and at Thursday at 6 p.m., an emergency sample, a patient comes in a sick condition, a sepsis, 6-year-old female, is brought to the emergency, and blood culture is taken. She's suffering from suspected case of sepsis. Blood culture is taken in a manual bottle, right, in a BHI bottle, and is sent to the lab at 7 p.m. The lab is closed at 4 p.m., right? Because everybody needs to go home by 3:30 because they need to catch a public transport because we had vacant seats at that time. So lab closes at 3 or 4 o'clock and no samples are taken after 3 o'clock. So that's the reality. So the sample arrives the next day on Friday at 10 o'clock in the morning and then it's incubated. And on Saturday at 11 a.m., blind subcultures are made on the sheep blood agar and McConkey on a Saturday without even testing what is the headspace turbidity. Right? It's a manual bottle. You could have done headspace turbidity observation. That's not done. Gram-Stain is not done. Blind subculture has been made. And then on Sunday, we get growth of a gram-negative bacilli, lactose fermenting. Of course, it's a holiday. And microbiologists are not supposed to work on Sundays. Right? So what happens on Monday? A manual IDST is done. And then still, there's no call made to the pediatrician. Because we don't like to call them. We don't like to communicate. That's the problem. What happens next is, on Tuesday, the reading is taken and the report is dispatched. And by Tuesday, the resident has already made the death certificate. That is the ground reality, and we are talking like this. So let us not be very negative. We can do a lot of good things despite having the conventional techniques or the manual techniques. How we can do that? You open up a 24/7 lab and accept the sample. So precision medicine will begin with how rapidly or how fast or how diligently you want to delve into diagnostic microbiology. Open up a 24/7 lab, accept the sample, and advise either procalcitonin or maybe a CRP. Next day, note down the headspace turbidity, make a gram stain, and inform the clinician by 10 a.m. So at least the clinician will know that some gram negative is growing. And do a direct manual AST and report the AST on Saturday. So you're saving at least 72 hours despite having a manual system. So that is the reality, and that is what we can do to improve upon it. It's not that I'm talking negative, but there's always a chance of improvement over here. So we know that we are towards the stairway to doom. We are on the verge. We have already arrived at this stage right now. We have not just the antibiotic malpractices, it is a misdiagnosis, the missed diagnosis, and the delayed diagnosis. So this is a classical case of delayed diagnosis, and we could have salvaged the patient because every hour counts in cases of sepsis. So we must know what is the exact target so that we should know the target so that we can give the appropriate treatment. So we know that AMR is a global pandemic, and all these national, international data have been telling us all these things, that 30% antimicrobials are given wrong, 50% are given wrong, and by 2050, at least 10 million deaths will happen globally. The Lancet study says that's quite a startling figure. What about India? What about Bharat? We don't know. But yes, the One Health approach has been adopted in the Vasudhaiva Kutumbakam program in the G20 summit. It's a good policy decision, but what about the individual patient? Well, we can adopt the antimicrobial stewardship approach, and of course, we have the CDC's core element, the 7 core elements for that. So we can practice that. But what about such cases? Such cases where we got a sick patient in the ICU with so many lines and NG tubes and catheters and everything, serious cases. So there are so many parameters involved that it becomes very, very difficult to have what we call as one size fits all. We have to make our treatment specific and tailor it to the patient, and that's why we need precision medicine. So this is the main article that I'll be referring to today, the antimicrobial or the antibiotic stewardship in the era of precision medicine. This is one of the paradigms that is used for the antimicrobial stewardship practices, and it has been able to pinpoint for the better patient outcome, the precision medicine in antimicrobial stewardship. Now we must know what is normal and what is abnormal, because unfortunately, like we say, somebody said that once we become MD microbiologist, we throw out our degree, our MBBS degree. So don't throw out a degree, you're still your doctors. So you must know what is homeostasis, what is the state of being normal, what is the state of being abnormal, because most of us won't know what are the normal laboratory parameters in biochemistry or in pathology. So we must know what is the normal and must learn to differentiate it from the abnormal, whether that abnormal is physiological or pathological. If it is pathological, has it got infective pathology or a non-infective pathology? If it is infective pathology, what could be the cause? If that cause is a true pathogen, it's a commensal or it's a colonizer. If it is a true pathogen, what is it? Bacterial, fungal, parasitic, or it could be multiple pathogens. So once you know the syndrome, if it is a GI infection, it's a possibility that you might get multiple pathogens. But if you're getting a sample from a sterile site, it is most likely to be a single pathogen. So that's the basic things that we must keep in mind. So we need to do mindful reporting. We need to do mindful reporting before we dispatch any of the reports. So the journey of the entire antimicrobials inside the human body is very complicated, especially if it's given orally. And the most significant confounding variables that we encounter in medicine are the diagnosis, and therefore the precise diagnosis and the precise treatment. Therefore, we need to have precision medicine. But before we go into the high-end omics, have we harnessed the full potential of the conventional methods? I just mentioned that you can still go in for active diagnostic stewardship even in all the manual conditions, right? So this is one particular CLSI document that tells you about the abbreviated identification of bacteria and yeast, and you can rapidly identify the bacteria and yeast if you go through this particular manual. So we were told, why do we need to do a process of pure culture? If you all remember, during our MD, we were told that do a pure culture exercise. So how does that help pure culture? So this is where it is helping in our day-to-day routine practices to improve on our diagnostic stewardship so that we can report as early as possible, because early diagnosis also is a part of precision medicine. So this is what we do. Whenever we get any of the bacterial positive, we do have a bacterial thanks to AIMS. We got it in our DPR equipment. So whenever we have a 24/7 lab also, by the way. So once we have a gram-negative in the gram stain, we immediately call up. It's a critical alert for us. This is the protocol that we actually follow in our lab. If we get a gram-negative, we put up the full battery of tests from that broth. We centrifuge it. We put the entire battery of biochemicals and the direct AST as per CLSI rapid protocol. If we got a gram-positive clusters, we take the broth. Now this is interesting, especially for the PGs and the SRs. If we got a gram-positive GPC in clusters, we take the broth, put up the tube coagulase, and when we subculture it on blood and MAC, we always put up a vancomycin disc at the primary inoculum. Because if it is a coagulase negative staph, it is there might be overgrowth and it might be covering the true pathogen, which could be gram-negative over there. So the gram-negative will grow somewhere around the vancomycin discs over there. And we do a direct AST. Similarly, if we GPC in stains, we put up bilesculin agar using the control stain of 29212. All our blood culture bottles, we weigh them, because we got an Excel sheet of 62 grams. That's the standard weight of the bacterial bottle. And once we get a bottle, we weigh the bottle, we note down and there's automatic deduction method is there. So it will calculate the exact ml, the weight, and then it is divided by the specific gravity of the blood. So we get the exact volume of the blood in our Excel sheet. So that is also recorded in our department. Now, what are the ongoing challenges with the AMS programs? Because why we need precision medicine? Because there are issues with the current AMS programs, like the challenges of differentiating bacterial from viral infection. That's a very major issue for all of us. Then delays in the pathogen diagnosis and AST due to technical limitations, because bacteria have their own generation time. Viruses we cannot grow, right? Similarly, discerning infectious from non-infectious conditions, and we must know all these risk factors when we are doing the reporting. If we don't have these risk factors in front of us, but what is the patient, what are the surgical procedures, what are different instruments on the patients, we will not be able to do what I again say precision medicine or a practical, you can say tailor-made medicine for that particular patient. We'll be just reporting SR, and I maybe, that's it. So all these parameters must be known. If you correlate with the figure which I showed you in the initial slides, the patient lying on the ICU bed. So precision medicine. Precision medicine is another AMSP tool that is designed to optimize the efficiency or therapeutic benefit for particular groups of patients using genetic and molecular profiling, right? It involves rapidly identifying the altered biology within a patient and using the findings to guide the therapy. So it was first done for the oncology patients, and then it was extrapolated to the infectious diseases also. So if you see about precision medicine, it is basically about precise diagnosis and the precise treatment. So the precise diagnosis can depend upon the metabolomic based diagnosis or the proteomic based diagnosis, or it could be genomic based diagnosis. Again, the treatment can be an antimicrobial chemotherapy or immunology based, which is being practiced right now, or it could be gene therapy based as well. So what are the omics, right? So Om is the study of the universe. This is the sound of the universe. So if we start implementing these studies into the specifics like the genome or the proteome or the transcriptome, so all these are the studies. So what is genomics? It's a science that studies the structure, function, and evolution and mapping of the genomes. So similarly, we've got virome, we've got fungome, we've got everything. So all these, so if we recall the central dogma of molecular genetics, that for every diagnosis or normal, what are the normal sequences, that always there's formation of DNA, then transcripted to RNA, then translated to a protein. So this is always that sequence that is formed, and it's a possibility that maybe the clinician someday will be able to use the omics test to simultaneously inform the treatment in real time. So precision medicine, the two major clinical syndromes where we need to apply the precision medicine is the diagnosis of sepsis and the viral pneumonias, right? And the precision medicine approach can help us distinguish from viral from the bacterial pneumonias. If we follow these core components of precision medicine-based antimicrobial stewardship practices, we have the evidence-based selection of antimicrobials with precise dose and duration. That is what we're following at AIMS right now. We are trying to do the tailor-made or the precise reporting for patient-specific reportings, surveillance of AMR and healthcare-associated infections, rational diagnostic approach, including omics-based testing. This is where we need to develop right now. And of course, reassessment of the antimicrobials after culture and AC reports. So we are doing a follow-up of all the inpatient reports as a prescription audit. So precision medicine, like I said, is about accuracy and rapidity of the diagnosis, how fast you're able to diagnose it. So the respiratory tract infections, skin and soft tissue infections, and UTIs, these are the three common syndromes where need to implement or the precision medicine, because that's where the maximum misuse or the misuse or the abuse of antibiotics is actually happening. So this is one study that was published. This is a prospective validation of a rapid host gene expression test to discriminate bacterial from viral respiratory infection. So the hypothesis of this particular study was, what is the ability of the host gene expression system to accurately determine the bacterial from viral infection in acute respiratory illnesses? So they found that, as we all know that in the rest, because I personally feel that respiratory samples are one of the most difficult to process, one of the most difficult to analyze and report, because you get a staph aureus and Streptococcus pneumoniae from the same patient, you don't even know which one is the true pathogen, which is the colonizer. So same issue happens, we have to go in for a pre-analytical and analytical, and that's where the precision medicine approach comes over here. And what happened in this particular study was, they found that the peripheral blood host gene expression assay that quantified the expression of 45 host messenger RNAs with a sensitivity of almost 90% and a specificity of 82% with a negative predictive value of 98% for bacterial infections. So this is one of the new approach that has come up, the omics approach for the diagnosis of the viral versus bacterial pneumonias. Now there's a downside to it. The downside is that one important caveat is that when we're evaluating these tests, it does not discriminate the bacterial from viral infections, that what is when to diagnose that this is an infection, this is a colonizer. Because this is the issue that happens with most of what is the actual microbiological insult, because you might get multiple pathogens. So if you see this particular report from a film array, when it comes to a sterile sample, samples are normally sterile sites, it's fine. You are likely to get only single pathogen. So we are very fortunate that we got, this is just, I've taken this report somebody else, this is not my report, we're not using BioFire right now. So in this case, Varicella zoster is isolated, that's fine. So what about this one? Specimens from normally unsterile sites. So this microbiologist is very, very lucky because he's got only one pathogen over here. But what about this case? What do we do in such cases? What is to decide that which is the true pathogen? So that is where the normal human intelligence will come over, and then your mindfulness in reporting will make you realize that what to report and what not to report, what is normal, what is abnormal, and that is why I put up that slide for homeostasis, as to one must know what is normal and what is abnormal. Now there are certain biomarkers which are used in precision medicine. It is something that we have read for a long, long time. What are the biomarkers? And that's a typical Three Idiots definition of what biomarker is. I don't want to read the entire thing. So biomarkers that we use most commonly and rather abused is procalcitonin. And it has got variable reports and variable samples in variable conditions. So we are not very sure as of today that is going to be the exact biomarker for precision medicine or not. But still we are using it anyway because it is a peptide produced by the parafollicular C cells of the thyroid, and it gets increased in concentration once there is systemic inflammation. So the issue with procalcitonin is that viral infections in contrast cause an increase in interferon gamma, which suppresses or inhibits the production of the procalcitonin. So to some extent, maybe it can take care of the differentiation between viral and bacterial pneumonia. Again, it comes to the judgment of the clinician and the discussion between the clinician and the microbiologist. So if we look at this particular publication, this is a very bold guideline saying that less than this, do this, less than that, do this, more than that, do this. So instead of doing that, we need to be, I said, mindful and think that PCT has got a good negative predictive value. Okay. It's got a good specificity but a poor sensitivity for the respiratory tract infections. It is useful in the diagnosis of post-operative infections like necrotizing pancreatitis, and its value or its concentration will decrease if there is a concomitant use of steroids. So we have to be careful and mindful when you're using procalcitonin as a marker for a precision medicine. Then again, precision medicine you can use for the diagnosis and for treatment. So in case of diagnosis, there are publications like the use of phages to detect bacterial pathogens, reporter phage-based detection assays, and they have been able to identify with almost like 97, 98% MRSA with a 6 hours of TAT in such studies. Then there's an issue with the UTIs. UTIs, how to differentiate between UTI and asymptomatic bacteriuria, because the issue with the very definition of UTI is flawed, because we think that the urinary tract is sterile. It is not. The very fact, it's an old notion that bacteria are not a normal part of the normal inhabitants of the urinary tract. They are. That is why now the term urinary tract dysbiosis is proposed to be the new term instead of UTI. Because every individual have their own urinary microbiome. It is unique to every person. So this is one of the cases that we discussed in our workshop with Dr. Ranganathan day before yesterday. Coming to the AI and machine learning algorithms in precision medicine. So there was another publication which studied 3 main areas of focus: predicting AMR using the genomic data, gaining insights in the cellular functions disrupted by antibiotics to understand the mechanism of infection of actions, and of course informing AMS decision using the data extracted from the EMR. I think the third point is the very common thing that we're using in our CDSs or the clinical decision support systems that we're using. Many of the softwares have been developed for that also. And I think WHONET does carry a lot of weightage in that, because we feed a lot of information on WHONET, and till we don't feed information onto it, till we don't digitalize information, till we don't digitalize our data, we cannot do data mining and we cannot extract the data into a workable treatment option. Then this particular study, it said that they designed 5 machine learning algorithms to make antibiotic sensitivity predictions using patient demographic data, culture results, and AST. So all these data we are entering in our WHONET. So like I was just describing with somebody that the moment, if let's say my MALDI tells me that this is Staph aureus, I have got the data with me that tells me, okay, the likelihood of this being MRSA is 25% and 75% as MSSA, so I'm likely to give a cloxacillin in this patient rather than going for a vancomycin or teicoplanin. Again, antibiotic treatment using precision medicine. So the initial part that we saw, these are the all parameters which will make us pinpoint and more precise when we are doing the reporting, because this is the ground reality, because if we don't consider all these issues, because this is again a part of precision medicine only, what we are doing currently. What is the source of infection? What is the most likely pathogen? Is it true or not? Is it a true pathogen? What are the patient comorbidities? So all these factors need to be taken care of before we go in for a customized AST report or a customized culture report, whether you are reporting antimicrobials or we are withholding antimicrobials. So this is basically the integrated stewardship approach. This is the integrated stewardship approach, and this is what we are planning, and that's what we are trying to follow in our institute also. Now, CRISPR. When I talk about CRISPR, this is something I can correlate this story with Amita ma'am had told me a long time back, that during the COVID pandemic, the principal secretary called up madam, madam, CRISPR kya hota hai? Sahi baat hai, ma'am? Yeah. So, ma'am said, I'll get back to you on that. So, if you ask me, I'll get back to you on that. So, when we talk about this definition, if the molecular microbiologists speak these things to me, I can correlate how I speak to the clinicians. So that is something, if you start reading it, I'll get lost somewhere. So again, but the CRISPR is one technology that is being used, that is being harnessed now for the treatment. So there are different CRISPR proteins are there, type 1, type 2, and type 6. They have been developed as specific antimicrobials to target specific organisms. Now there's another very interesting publication, the targeted therapeutic strategies in the battle against pathogenic bacteria. So this includes narrow spectrum agents. Now there are many agents which are not given in our M100 documents or our CLSA documents, which are targeting specific pathogens. So these are the narrow spectrum agents. These are not like, you can say the norfloxacin or something like that. They are very, very specific agents. I'll just show you a table on that. Then we've got antimicrobial peptides, also known as the host defense peptides. So these are also being researched upon. Narrow spectrum lysins. We've got engineering or engineered probiotics, which include the transporting specific antimicrobial molecules, the bacteria-specific sense and kill systems. We've got nanotechnology, and nanotechnology is being extrapolated to the specific treatment guidelines, including antibody-based targeted nanoparticles, peptide-based targeted nanoparticles, membrane-based target nanoparticles. Then, of course, we've got the fast therapy that is, I think, being developed to quite some extent by Dr. Gopalnath at BHU, and he's published many papers on that also. So, fast therapy also in combination with antibiotic and phages, and of course, the CRISPR-Cas9 technology. These are the specific the narrow spectrum antimicrobials which are being used, like for example, fidaxomin, specifically used for Clostridium difficile. There is no guideline to check or to how to use it, but it is there. So there are specific antimicrobials which are there, which are targeting specific on a single the bacterium only. Now comes the actual ground level reality, what we can do right now. This is a TDMX software that is freely available on the internet, where you can choose your antimicrobial that you want to give to the patient, depending on the patient's age, patient's weight, patient's height, sex, what are the dose that you want to give or duration, the dosing interval, whether you want to give it as 8 interval or 8 hours or 12 hours or 6 hours or 24 hours interval, and accordingly, it will tell you what MIC you are aiming at. If your MIC is 2, then you enter over here and then it will calculate the dose for you. These are the typical patient-specific dosing. Then in the same software, we have got what you call as a Bayesian dosings. In Bayesian dosings, when you enter these options, so it will give you what is your percentage of target attainment. So if your percentage of target attainment you want to be as high as 100%, and your PK/PD target. So PK/PD target will depend on what kind of antimicrobial you're dealing with. If you're dealing with a concentration-dependent antibiotic, so that PK/PD target will be something else, probably 10 or something. If you're dealing with the antibiotic like vancomycin, in that case the target will be around 400. If you're dealing with carbapenems, that should be at least 40% of the time above the MIC. So like in this case, I've entered 60% over here. This is for meropenem, I think. And then we calculate the Bayesian dosings. So what they try to tell you is that if you have, now these green lines, the green ones are the ones that include the successful treatment. So if you want a percentage of target attainment of at least 90%, you need to have a 2 gram dosing every 4 hourly for, it's a 4-hour dosing for 3 times a day. So if you are using 2 gram of meropenem 3 times a day in a 4-hour extended infusion, then you are likely to attain a 90% target attainment. But if you're using, that is around 6,000 milligrams per day. Now, if you're using the same 6,000 milligrams as a continuous infusion, you're likely to get a 100% target attainment. So these kind of precision softwares will tell you how to dose your antibiotics. So this is exactly what we're trying to do in AIIMS Mangalgiri also. This is the snapshot of one of the reports that we are making. This is a gram-negative, that's the E. coli isolated from blood. And as you can see that we have done cascading of carbapenems. We have done cascading of colistin. We have reported only the BL-BLI combination and few of the aminoglycosides. We've even restricted amikacin over here. And we have mentioned specifically that this ESBL positive, AMC is negative, carbapenem is negative. Please see the footnotes. So this is the breakpoint to MIC. This is the same report only. Breakpoint to MIC quotient reporting that we are doing. And we have cascaded amikacin, we have cascaded amoxiclav, and we have reported cefepime as an SDD because the MIC is 8. So 2 divided by 8 is the SDD of 0.25. So that's the actual AST report that we are sending. Then in the reporting, all the antibiotics which are resistant that we are reporting, and we are restricting like imipenem, meropenem, of course, tigecycline and colistin also, and phosphomycin. So all that we are releasing is piptazo and genta, and that too how? And those antibiotics which are not in the Vitek panel, we put up the extended panel of antibiotics as a Kirby board distribution method. So the above this line is all our MIC, and below this line is the KBDD extended panel for the 405 panel, for which extended antibiotics are put up. And what do we advise? This is the third part of the report. This is what we advise. In this case, best treatment option is based on the PK/PD profiling. The carbapenem sparing option is gentamicin in this dose, followed by time gap of 30 minutes. Then use piperacillin tazobactam, either 4.5 gram 8 hourly over 4 hours extended infusion, or 4.5 gram 6 hourly over a 3-hour infusion. So we are being very, very specific and precise that this is what it's supposed to give, and this is what we follow on the next day in our prescription auditing, and we give them an option for an oral step down also. This is another report. Now, this was a Vitek report, but can I practice precision medicine in the absence of automation? Yes. So there are certain times when we don't use the Vitek, we use the Vanco and the TICO E-test. We are using normal KBDD. This is a case of an MRSA from a bone and joint infection, which is D-test positive. And of course, we reported Ticoplan as a drug of choice and not vancomycin. Why? Because once we put up the MICs, yes, sir. Once you put the MICs over here, we can see that the Ticoplan breakpoints of VMQs are much higher and it's going to be much more effective than vancomycin. And of course, Ticoplan is much less nephrotoxic as compared to vancomycin. And this is the alert that we send about MRSA, what MRSA exactly means. So the innovation that we are doing at our department, that we have remodified the modified horse test, and it still is useless. We have incorporated that in our CRE templates. We are daily putting our CRE templates. We have developed few tests like the macro broad disk illusion dilution method for the SEPTA IV Astronom synergy testing. We are also doing a FICI or the fractional inhibitory concentration index combination using the Vitek cards, which even the biomiro people don't know about. We are practicing precision medicine just the way that I told you, that we are making patient-tailored reports, footnotes, resistances, dose, and the posology, and in what sequence you're supposed to give the antibiotic. We do have a 24/7 integrated lab. That's the white, red-colored board. That's the integrated stewardship lab that we got, and that's our faculty over here. We have implemented the AMSC snakes and ladders in all our wards, and all the surgical, gynae, and the peds and ortho wards, they are using the beta-BL-BLI combination in extended infusions of 3 hours only. So that's our integrated stewardship lab. So the way infections don't take holidays, should microbiologists take on holiday? And like Vatal sir said in the previous workshop, if you have the passion, you will always have the time. With that, I end my lecture. Thank you so much for your kind patience.
Thank you very much, Dr. Sumit, for a very nice presentation, particularly concentrating on the ground realities and what we are trying to aim at and how much we can achieve at this moment. The next speaker will be none other than Professor Amita Jain, who is the chairperson of the organizing committee of this, of this conference. Professor Amita Jain is a fellow of Royal College of Pathologists, Infectious Disease Society of America, NAMS, and technical mentor and member of many of the expert groups, particularly on tuberculosis and many others. She has more than 300 publications indexed in international and national journals, more than 20 different grants and research projects carried out of which 7 of them are multi-centric research projects. She has received Professor U.C. Chaturvedi Oration and Lifetime Achievement Award, IAMM UP chapter in 2017, and her research interests are mainly virology and tuberculosis. So Professor Jain, please, for your presentation.
Thank you, sir. Thank you for your very, very kind words. At the outset, I must thank Dr. Pallab, who has thought that I'm worthy of this symposium's presenter. Thank you, sir, for bringing me here. So, good morning, everyone. I bring you greetings from King George's Medical University. Okay. And this is the name of the symposium, which all of you have seen. I'm going to talk about the tuberculosis. There are few points which we'll be discussing. I must congratulate Dr. Pallab for making it very thoughtful. When he has given the topics and gave us very broad outlines, I was almost sure that there's going to be 50% repetition, sir. But to my surprise, there's very minimal repetition, which I didn't expect. So thank you for giving us so much of leverage and then making it so good. My previous speakers have talked a lot about precision medicine, how to precise the treatment in bacteriology, and in virology. I'll just very briefly touch upon what is precision medicine. Then I'll briefly tell about the load and magnitude of TB and drug-resistant TB, how we currently are managing TB, very briefly again, and how we should do it, where I'll try to bring in precision medicine. And if we do that, what is the expected outcome of that? So with these objectives, I'll be starting. What is precision medicine? Does one size fit all? No, it doesn't. So that is precision medicine. So it's an approach for disease treatment and prevention that takes into account individual variability in genes, how we are all different, environment in which we are in, and the lifestyle for each person. So that is the classical definition of precision medicine, textbook definition. When we apply it to the clinics, it very much resonates with our AMSP themes. Right intervention, right time, right patient. Precision and personalized medicine. These are the two terms which are used often synonymously. Actually, they are. But preferred term is precision medicine. When we say precision medicine, we apply focus on the patient based on patient's genetic configuration, the environment, and the lifestyle factors. So if you look at this picture, you can see that here, can you see an arrow? No, you can't. So if you see in this picture, what you see that these all people are phenotypically looking different. When you take them to the laboratory, you kind of categorize them based on your laboratory test, which you have seen that two previous speakers have so beautifully done. And then you choose the treatment, the pink one for pink, yellow one for yellow, and blue one for blue. That is personalized medicine. So if we look at this picture, we understand that this is the patients which are poorly characterized. Then we have put the precision medicine, we have seen that how they are different, and then we have brought them and given them the treatment which is personal for them. So they are basically the same term with very, very small difference in that. Coming to the big jump, where the term precision medicine came from. And this is a very, very, very famous address which President Barack Obama, US President, in his State of the Union address said, and after that he used the word as precision medicine, and 1 month later, Director of NIH authored a perspective piece in the New England Journal of Medicine, which supported a personalized approach to disease therapeutics. Obviously, the main focus was malignancy. However, he also said that other diseases are amenable to a very similar approach, including infectious diseases. This is the address which was published, following which the New England Journal of Medicine letter was published. If you look at the precision medicine and infectious diseases, we will realize that most of the focus is on malignancies. There is very limited focus in infectious diseases. There's a genome-wide association study catalog known as GWAS. GWAS mainly talks about how many, there are too many associations which have been talked. Till 2020, I have got this data, where only 1.8% publications in this GWAS was infectious diseases associated. And only 1.1% associations were mentioned here which were related to infectious diseases. So now the big question arises, will precision medicine approach in infectious diseases would be effective? Do we really need a personalized medicine and precision medicine for infectious diseases? I'm raising some questions here, and then I'll provide you the answers for these. Why do some individuals present with lepromatous form of leprosy while others present with tuberculous form of leprosy? So this is a question. Why do certain HIV-infected individuals spontaneously control infection to very low viral loads, such as the elite controllers, while others develop the full-fledged AIDS? Why do some individuals reactivate herpetic infections with devastating outcomes, while others maintain herpetic latency? Why do certain people with similar and identical risk factors develop fungal complications while others don't? Answers are again lying in some questions. We do not have very straight answers most of the time. Do unmeasured variables exist within the individuals? Will our patient respond to treatment as we are suspecting or proposing? Can they afford to suffer a clinical treatment failure? What are the factors that allow one patient to control infection but others to fall gravely ill with that? Inherent to these issues are two variables. One is pathogen and other is host. Significant amount of research has gone in pathophysiology of pathogens, and equal focus should be given on host also. Somehow when we talk about infectious diseases, we talk of pathogens. We say that what is sensitive, what should be the regimen, and things like that. Most of the time we forget our host, that how he or she is going to respond to it. Coming to the tuberculosis. This is the latest WHO report on tuberculosis, which was released about a couple of weeks ago only. This report says that number of newly diagnosed people in 2022 were 7.5 million. This is the highest number of TB patients, newly identified TB patients, since 1995, WHO started investigating. And they thought probably there is a backlog of the patients due to the COVID impact, which have been counted here. Similarly, the TB-related deaths, estimated deaths were 1.3 million, almost 500,000 excess deaths from TB in last 3 years. And this was also called a COVID impact. If you look at this picture, it's very, very clear picture. Every WHO report has this picture. If you see, there are three colors you can see here. There's a blue outline, there's a red outline, and there's a yellow outline. Yellow outline talks about TB, how much, red outline talks about TB, how much is the TB. Yellow talks about TB and HIV, and blue about MDR TB. Where are we lying? We are lying here. This is India. And we have all the three. Like we have a heavy load of all forms of TB, including TB, HIV, and MDR TB. Other countries have 2, 3, some have all. These are the TB deaths. And this is again from the WHO same report. Here you're seeing that, sorry, okay, this is working now. So you see that this is the TB death. It has come to this level. Now it has increased in 2022, and it has again come down slightly. So again, probably that was COVID impact. At least that's what the report says. This is from other sources where they have measured the TB death in percentages. These are 3 different sources. And what we see is nearly 2.5 to 3% people with TB do die still. If you look at this picture, it says that you can see the big blue dot on India. And if you see, this is more than 20 lakh people. So India has a big number of TB, which WHO report says the latest one. So what we do currently, how do we manage TB currently? For the many decades, for many past decades, what we have been doing is that we are categorizing TB patient. Initially, we were doing based on only one thing, that if patient has received the treatment in past or not. And we have made the regimens accordingly. So if you have been treated in past, you get this regimen, not treated in past, you get this regimen. So that was the kind of TB management. It was really impersonal. Like, as a result, lot of TB patients were getting complications, they were not responding to treatment. So one step came in when we started detecting at least rifampicin resistance using a molecular assay. And with that, GeneXpert or TrueNat, which we are using, a made in India test. So what we saw that at least we started characterizing our patients based on some genotypic laboratory test to diagnose rifampicin resistance and saying rifampicin sensitive, give this, rifampicin resistant, give this. So 2 regimens were decided, again, mainly based on rifampicin resistant. Again, we saw that no, the result is not as we expected, so they have added more drug susceptibility testing data into it. So basically what we are doing, we are categorizing patient based on rifampicin resistance or other drug resistance. What we are forgetting? We are forgetting is human immunity, pharmacokinetics of the drugs, variations in the pathogens, as Dr. Pallab has in the beginning said, that even the same strains may be different, and further microbial characterization based on that. We are also forgetting patient tailoring regimen. Regimens tailored according to the patient need, based on at least patient body weight. What we do is only for children and for very low weight patient. But a patient who might be 60 kg, who might be 80 kg, who might be 100 kg, all of them are getting almost same regimen. So patient characteristics are still not taken into account. This is the algorithm which National Tuberculosis Elimination Program is using correctly. And you see, at least if you see the, I think last 4 or 5 years old report and you compare, there are more categories here. So they say that apply a NAT, look for rifampicin resistance. If it is detected, do that much, look for the report. Then there are more than 2 or more than 3 or more than 4 categories which are available. If it is rifampicin resistance not detected, still look for an INH resistance at least. If detected, do this. So there are more characterization of patient which is done based on the anti-tubercular resistance. This is Indian government's report, tuberculosis report, which has been published recently. What should we be doing? This is what we are doing, what we should be doing. In my opinion, or anybody's opinion, I think if we apply the personalized medicine on treatment of tuberculosis, there should be at least 4 areas where we should be working on. And, sorry. This is a very smart document which was published in Frontiers of Immunology. My further slides are based in that document, and I acknowledge this. So tuberculosis patients may be categorized, number 1, based on next generation sequencing of M. tuberculosis DNA to find out resistance, at least if nothing beyond. We can predict drug susceptibility based on genetic sequences, and we are progressing in this direction to a great extent these days. I'll be discussing it at length. Point number 2, host immunity. We understand that all the damage, all the pathology caused due to tuberculosis is not only because of microbe. lot of role is played by human or the patient's immune system. Some people who have very, very exuberant immunology, immune system, it has to be controlled. We have to manage it somehow to suppress it because there can be immunopathology because of that. Some people have suppressed immune system, so it has to be helped, it has to be enhanced, augmented, so that patient does not suffer further damage. The third point is the individualized drug concentration, and I was actually depending a lot on Dr. Sumit to talk about it, which he has done to great detail. There's no basic concepts different. Antitubercular, antibiotic, whatever, but when you are giving some drugs, are you measuring it? How much individual, patient-wise, how much drug should be given to this patient and at what intervals? Sadly enough, for tuberculosis, we are not doing anything. For host immunity, we are not measuring. Biomarkers. Then again, one thing, TB is a chronic disease. Once a patient gets TB, we have to treat the patient at least for 9 months, maybe more often. So when you are putting the patient for 9 months on a treatment, what are your markers to decide when to stop the treatment? It cannot be same length for every individual. And what are the markers we are using currently? I'll talk about them briefly, and then what should we be doing about it? That should also be discussed. So keeping these 4 things in mind, first point is the drug resistance in TB. We all understand that drug resistance in TB is mediated by genomic variants. There are SNPs which happen in the gene of interest and which causes drug resistance. It's not transmitted like other bacteria from one strain to another. If it's transmitted, it is transmitted from mother cell to the daughter cell, or it is de novo developing because of the environmental pressure or genetic mutations which are occurring de novo. These SNPs can be detected easily using next generation sequencing. And detection of these SNPs can replace phenotypic DST, which we have seen in case of rifampicin resistance. The tests which are available, genotypic tests which are available, the results are available within few hours, are good enough to diagnose rifampicin resistance with a sensitivity and specificity of 95%. So these are very good tests. Unfortunately, the same level has not been reached for other antitubercular drugs. Why? Because the data which is available, resistance mutation data, catalog, database which is available is very, very limited. So accurate TB diagnosis and DST is required to guide selection of appropriate antituberculosis medicine. Treatment success rate for MDR TB in India, currently using SLD, is approximately 56%. So almost half of the patients do not respond as we expect using SLDs. Genotypic DSTs can predict resistance to first-line drugs fairly enough for INH and good enough for rifampicin. But resistance prediction for some drugs like ethambutol and pyrazinamide is difficult. Why is it difficult? 2 main reasons is that there is breakpoint artifacts. So what we think, what we see phenotypically is not translated genotypically same to same. And then there is a current knowledge database gaps. For drugs like PAS, D-cycloserine, thiamides, linezolid, meropenem, etc., data is very limited, very small data bank is available. So when we talk about geno to pheno prediction, when we say that if this mutation is present, this is going to be sensitive or resistant, there are certain programs which are being developed. They're filling in, they're revising on day-to-day basis, more data is coming up, and we are looking at some promising future tomorrow. Gets stuck. Okay, this is an Indian catalog of our database, which was published last year. This data bank talks about 3,167 M. tuberculosis strains, which are collected from 25 states in India and some union territories to make this document. However, I have seen this document. It's really, there are a lot of gaps. I've seen especially for linezolid, they talk of only one mutation and they say it can predict resistance up to the level of 50% only. So there is a lot of data gap in spite of the fact that more than 3,000 strains have been admitted here. The second point was endotypes. So if we can characterize our patient based on endotypes, we will be able to provide some useful treatment. What is endotype? Endotype is a term which was used mostly in reference for the asthma patient. They talk of categorizing their patient based on their immunological status, basically, and secondly, their genetic characterization. If you look at this picture, here you see that there are 3 types of phenotypes. But when you start further characterizing them, you will see that each phenotype has certain characteristics in them which are different, and you get some subgroups within that. This can be done, this is in relation to, this picture is in relation to asthma, so it's more apt for that, but we can apply it here to understand what is endotyping. So if we say that this individual, they'll have some extra respiratory and some respiratory factors. There can be lot of them here, lot of them there. So this individual, based on these categories, when he was categorized, you see that there are so many endotypes which could be created. So he might be different in the weight, he might be obese, he might have osteoporosis, may not have it, some psychological factors. So lot of factors were taken into account to categorize an individual, and so many types of endotypes were created. This is just to understand. So if we give a definition, we'll say that understanding and grouping of patients according to disease mechanism based on genetic predisposition, treatment response, and altered molecular pathway is concept defined as endotyping, and they are basically characterized by immunological, inflammatory, metabolic, and remodeling pathways. In reference to TB, I think if we talk about it, there are 2 endotypes which we should be concerned about. One is immune deficient or immune exuberant. Immune deficient has certain factors which are low, like deficiencies in the interleukin 12, interferon gamma, interferon pathways. There are a lot of molecules which have been described as deficient. I have just written few here. They result in decreased intracellular killing of MTB, so response is different. Exuberant responses, I have taken few examples here like interferon gamma or TNF alpha. This result in pulmonary and macrophage necrosis and the escape of viable MTB into extracellular spaces. So depending if they have deficient or exuberant immune response, the outcome may vary. It may not be same as in a homeostatic person. So that's what we do not do still for TB to understand that how this individual is going to respond. What are the bottlenecks? Why we are not able to do that? What we used to do in pre-antibiotic era, we used to give some sun therapy, good food, enhance immunity, isolate the person, and 20% of them used to respond, rest used to succumb to TB. What we do now? Next phase, in relation to endotyping, should be harnessing and targeting host immunity while minimizing immunopathology. So whatever microbe is doing, we are giving anti-tubercular drugs for that, but at least the host immunity should not cause further damage. A study of immune deficient versus immune exuberant model. Transcriptomic immune function studies both had baseline and upon antigenic stimulation and pairing all those omics which we have been talking about. Therapeutic drug monitoring, Dr. Sumit has covered it very well. We have understood that how it goes, but we have to understand that which patient needs more drug, which patient needs less drug to avoid two things. We want the best response. It should cause microbial killing, and we should not have adverse drug reaction. So therapeutic drug monitoring is very important. We have been doing it for antifungals very well, some antituberculars very well, but for antituberculosis drugs, we have not thought about it still. So we cannot give high and low concentrations to everyone. We have to see who needs what. I'm skipping this. This is kind of repetitive. Then last point is biomarker-based treatment decisions. We do not have any test which is a good biomarker to decide when to stop TB. What we do today, we actually look for some bacteria in the smears. We do some cultures, we do some gene expert, some patients like HIV positive population, we may measure LAM, we may do a detection of mycobacterial DNA in the stool samples. Many of these tests have yet not been implemented in any program for determining the end of treatment, except culture. There is a concept of molecular bacterial load assay. Can it help? It's a subject to debate. I do not know. But if it correlates with culture positivity, it is rapid, definitely, and it is not compromised by culture contamination. So this is a positive point in favor. It may correlate with disease severity. We do not know. And if it can provide information on the bacterial effect of different drugs, it may help. It can have potential of identifying those patients which are not responding to treatment. It may have some potential on finding a patient adhering to treatment or not, which is again a challenge with TB patients. It's such a long treatment. So this has not been put still under the operational research. So there is a potential on molecular bacterial load assay. Then there are many more tests which are available. None of them have been tried. I'll just say, for example, PET-CT, computer-aided diagnostics by X-rays, T-cell activation markers. These all are tests which have been described in literature, but their potential as a biomarker to decide that when to stop treatment has not been tried yet. So my summary slide, just few points to make. Tuberculosis, supposedly a treatable disease, but it still has high mortality, which is around 2 to 3%. Management has improved significantly in last decade based on some lab-based markers. Probably tomorrow we are expecting that we will shift to genotypic DST, which will improve the treatment protocols. Endotyping and DST-based protocols will be ideal, which is still not available. And we definitely need biomarkers which can give us a rapid result and tell us when to stop the treatment. With this, sometimes this works, sometimes this works. So there are many important questions which need to be answered. Do we need precision medicine? Can it be applied on infectious diseases? Do we need more studies in this area? Who will be benefited? Does it apply to resource-limited setting? Shall it be part of our curriculum? I think, in my opinion, answer to all these questions is yes. With this, thank you very much. Thank you for your patience.
Thank you, Professor Amita Jain, for an excellent presentation. I will request all the three presenters to be available here. We have about 5 minutes that we can have interaction with the audience. Dr. Amita, please take your seat here. And by the time they sit there, I'll request the chairperson, Dr. Aarti, to give her comments.
One quick thank you so much, Dr. Pallab,
for this efficient organization or moderation of this symposium, because it's a very vast subject of the knowns and the unknowns. And very beautifully, as much as ground could be covered by three speakers, Dr. Amita, Dr. Ekta, and Dr. Sumit, has been covered. But as of now, it is mostly starting from what we have, what potential we have from the existing facilities, from the diagnostic, more specific, rapid, for the treatment, antimicrobial stewardship. So all that, and Dr. Amita to some extent covered that unknowns. So finally, if we want to reach the next level of precision medicine, I think that we need to study much more in terms of the host genomics, host gut microbiome or microbiome. Probably that is the next future, if we say precision medicine, and some of the environmental factors which we have yet not much idea. So I think using this conventional and basic approach and going to that level would be the future. Thank you.
Thank you very much. We have a couple of minutes because I will love to hand over the stage for organizing the executive committee, the general body meeting at 12. So any comments? Yeah, sure.
I've got few comments to make. I was just trying to look into the whole topic in perspective of our infectious disease or microbiology. If we see in case of the microbiology, what are the real changes in my life of 30 years? Most important thing I would say that we have now the MALDI, which gives a very quick identification. That's a big discovery which had happened and which is being implemented in most of the area. If we look into the genomics area, of course PCR had come, sequence had come, but if you look into the diagnostics aspect, it is mainly used in case of viral infection. In case of the bacteria, fungus in other area, still we are differentiating the contamination, colonization, and infection. We are still not so good validated area which come out in case of diagnosis. In case of the one area where genomics has played significant role is the understanding of the taxonomy of the microbes, the differentiation, and that taxonomy ultimately helping us to a great extent in case of surveillance, in case of outbreak. And that outbreak surveillance is being used with this genomics area. But if we look into the precision medicine eyes, yes, there are certain things which have been well discussed in this meeting. But in case of this resource limiting environment, we have to think about few things. First is, have we got that expertise so many? What we have found is that if we can have bundle of care, very precisely can be mentioned, that can be trained people much easily. If we want to have like suppose this particular patient have osteoporosis, this particular factor, this factor, so how we manage, we need Rajiv Suman type of person to give the therapy in that particular person. But these numbers are very less. So we need sometimes in this area, bundle of care which can help in case of resource limiting environment. Possibly, we have to go for instead of clinical infection to the biological infection. And possibly we have to go for point of care test. So I think in case of our young people who are sitting here, yes, there are several small areas where we have development. But if we have to think about in a real change in case of paradigm, in case of this infectious disease, possibly you have to think about these are the some obstacles where we have to think about and how we generally can go. One aspect I forgot to mention is that tissue damage. How we can quickly think about where is the tissue damage. There now the bisulfite sequencing is coming up very significantly, which possibly can help. And my feeling is that like cancer diagnosis in genomics, I also think that cell-free DNA detection possibly in future would be very important. Thank you.
Any other comments from the audience? Yeah, Dr. Ravi.
Congratulations to all the three speakers. Very well done. As I was sitting and, Arunalok and I have reached a stage where reflect more and work less now. So my reflection is, some of these ideas that have been put forward today in the three topics, all three are very, very important topics: virology, AMR, as well as TB. TB is a burning subject. I was thinking as an association, we have so much of expertise, may not be in one place, but scattered. Can we think of, as an association, deciding on a protocol, uniform protocol, getting it implemented through PhD projects or MD students, addressing these questions, something like what, I'm taking an example of what Dr. Amita Jain said. There are many places for TB, right? You have expertise for genomic sequencing extensively in NIRT and so many other places. So you work out the protocol, you work out the questions, break it down into small projects and get it done. So that in a short time, we will have answers to these. I think we have to move forward. We have been together for 46 years. We're comfortable with each other now. I think this is something that I would like the association. I see Dr. Sonal, Dr. Aarti, and others who are in the association. I think take one topic, do it as a pilot, and then you can scale it up. Thank you.
Fantastic. It should be a trendsetter. And we should all seriously consider the same. Any other comments from the audience? Otherwise, do you have any comments to make?
So taking the lead from both the honorable microbiologist and senior microbiologist said, so it's very, very right, because at this point we have more questions than the answers. And to find answers to these questions, we have to at least move ahead, do something, and this is an organization which can take it forward. And one more important thing is, sir, that finally everything is implemented at the government level. So unless we make some recommendation which is based on some hard data and take it to the government, that research will never see the light of the day. So together as association, now fortunately we are a big association, we have a strength, we can do some research, can kind of generate some data and show the government, if we do this, this will be the outcome. That's my question.
Thank you. So it's 12, and thank you very much. Thank you all the speakers,
I'll just
Dr.
request,
Aarti, and the audience.
Please
Thank you so much.
Please stay for 2 more seconds. I'll request Dr. Aarti ma'am to please felicitate our moderator and speaker. Dr. Ekta Gupta, ma'am, I request you to please felicitate her. बीच में आगे आ जाइए मैम. हाँ. Dr. Sumit Rai. And Dr. Amita Jain, ma'am. I'll now request ma'am to please give a token of appreciation to Dr. Pallabre for an excellent moderation of this session. मैम सर को तो दे दीजिए. थैंक यू सर. वो हाँ वो तो
मैं पानी उठा ला आपके लिए भिजवा. अच्छा आप ये लीजिए, मैं अंदर से
अरे ले लिए ना आपको चाहिए वो इतने सारे पड़े. नहीं रख दे बेटा. Good afternoon, everybody. I will request the members to please come forward in this block, this center 2 blocks, and the non-members to please shift on the 2 side blocks. Before we begin the general body meeting, I would request the members to please come forward in the 2 central blocks. Thank you so much. The copies of the newsletters which have been released by IAMM, the audit reports of IQAS, IJMM and IAMM are all placed on the stage. There are a few copies of souvenir also from the organizer side. So if anybody wants to have a look at any of these copies, please pick up. The agenda copies are being circulated and some will be kept on the podium. All the life members, annual members, student members are requested to please come and occupy the central part, the front rows.
Morning.
वो जो वॉलंटियर्स है ना तुम्हारे इवेंट वाले, उनको बोलो 2-3 कोऑर्डिनेट मीटिंग नीचे रहे। हाँ हाँ हाँ। The attendance sheet is being circulated. Good afternoon, everybody. Before we begin the GBM, I will request Dr. Aarti Kapil, President IMM, Dr. Manoj Kumar, Treasurer IMM, and Dr. Chand Vatal Sir, Editor IJMM, to please come on the dais. अरे मैं इसी से कर लूँगा। अच्छा, इससे आगे जा रहा है, इससे पीछे जा रहा है? ठीक सर वतल सर as the life members of IMM are 3,800 and this appears to be a quorum smaller than this, I am notionally disturbing the and reconvening after a few minutes to complete the quorum. Requesting all of you to please settle down. Yes, I have already told the volunteers to go outside and announce. Ma'am, gaye hain wo. The volunteers may please go out. Few of us are assisting from MAMC. Please go out and call Nilakshi. Call everybody from outside and bring them. So the meeting is reconvened. I would now request the chair, Honorable President Dr. Aarti Kapil, to please start the GBM.
Thank you, Dr. Sonal. So I welcome everyone and I declare this GBM during this 46th annual conference of IAMM 2023 open.
Thank you, ma'am. So with the permission of the chair, the general body meeting is hereby begun with all the members in attendance. Leave of absence to executive members Dr. Camilla Rodriguez, the ex-president, and to Neeraj Goyal is granted due to some personal reasons. Dr. Sanjay Biswas, the joint secretary, is noting down the minutes of the meeting. Before we start the GBM, I would like to place on record and remember certain people those people we love never go away. They walk beside us every day, unseen, unheard, always near, still loved, still missed, and forever. And we lost two such eminent microbiologists this year. Dr. Abida Malik, a beacon of knowledge, wisdom, and humanity. Professor Malik dedicated her life to the pursuit of science, education, and betterment of public health. Her passing is not just a loss to the academic community, but to many lives she touched and inspired during her distinguished career. She was an alumni from JNMC AMU Aligarh and led the department with passion and care. And what made her truly remarkable was her empathy, humility, and kindness. Incidentally, she was my examiner also, so I owe my success today a lot to her. Another stalwart we lost was Dr. Prem Singh Nirwan, former HOD Department of Microbiology at Jawaharlal Nehru Medical College, Ajmer, and ex-principal and controller, Government Medical College, Kota. A fountainhead of knowledge, passionate mycologist, and always a source of inspiration, he's left behind a rich harvest of memories to cherish, honor, and emulate. And I request all members a 2-minute silence in their memory. Thank you. The agenda hard copies have already been circulated. For those who did not get the copy, the agenda is projected. We start with welcoming of the new members to Executive Council and farewell to the outgoing Executive Council members to confirm the minutes of the meeting held at 45th IMM Conference, Bhubaneswar. To deliberate any action that needs to be taken on the minutes of the GB meeting last year, the annual report of the Secretary, which has actually already been read in inauguration, but I'll be presenting a brief here. Editor's report and statement of IJMM account, presentation of annual statement of IMM account, report of IMM ICWAS by the 3 coordinators, selection of topic for the 47th IMM conference and decision regarding the venue of this conference, decision regarding various awards of IMM, election of office bearer notification, and proposal suggestion of any training program, PG Assembly, IJMM, PG Masterclass, and any other matter with the permission of Chair. The agenda has already been circulated in the newsletter with the notification of this general body meeting. So this year we had 6 vacancies of Executive Council, and I very heartily welcome, I request the respective EC member when I call out their name to please stand. Dr. Rakesh Singh from JIPMER, Dr. Anupama Kindo from Purur, Chennai, Dr. Said Tanwar Alam from GMC Guwahati, Dr. Yogesh Kumar Gupta from Birla Hospital, Jaipur, Dr. Sarita Mahapatra, our very active quiz master from AIMS, Delhi, and Dr. Sunil P. Liliani from GMC Dhule. We would also like to place on record our sincere appreciation and thanks to outgoing members, Dr. Manoj Kumar, who served as treasurer for 3 years from RIMS Ranchi, Dr. Shivendra Kumar Shahi and Dr. Neeraj Goyal, who've completed their executive member term. A big round of applause for all the outgoing members. The GB minutes were circulated in the January 2023 newsletter, which has also been placed on the podium. So if we can confirm these meetings, can the proposal be proposed by somebody? Colonel Nagendra is proposing and Dr. Nagmoti is seconded. So the minutes of the general body meeting stand approved, which was held at the 45th IMM conference, Bhubaneswar. Now, there were certain points which were mentioned in the GB meeting. IJMM to increase 6 issues from 4 from January 2023, and the articles will be given an immediate DOI without any page numbers. This has been done by the editorial team, so a huge congratulations to the editorial team of IJMM. The next was purchase of lyophilizer by the South Center. Now this is still pending and I would request Dr. Balaji sir to please update us on this. They are going to do it this year. So they are working out the modalities and they will purchase the same model which has been purchased by the North Center, and so there is no other issues related to that. Nahi chal raha. Okay. So from the any other agenda last year, there was a purchase of land and ready-to-use office space. After a lot of deliberations, there were some suggestions made by certain members regarding the sites, but they did not fit. They were either not fitting the money that we have, or they were not fitting the purpose. So for this project right now has been kept in abeyance, keeping certain things in mind, which I will come to that later on. And this was approved by EC that let it keep it in abeyance for some time. So we'll have this discussion later on. PG Masterclass was another agenda, and as you all know, we've already started this from January, except for June, where we took a break because of students' examinations. All other months, we've had this PG Masterclass. Pathology and Rheumatology Association had approached Dr. Patil for formulation of guidelines, immunology guidelines. When they spoke to me, I did not find any merit there. What they wanted from us was very deceptive. They wanted us to give up the immunology to pathology. They said ANA, anti-CCP is not the domain of microbiology. It is still included in your curriculum. The immunology laboratory is part of NMC. That was my argument. And then it was that once we formalize a kind of a joint statement, then the immunology section, they would be putting it up in their pathology association. So I refused any more deliberations with them so that we stay status quo. The other was the IMM to bring out its own guideline. Now we did publish this guideline as paper with the help of Dr. Ravi, President Ma'am, Dr. Kapil, Dr. Sanjay and myself, where we published these guidelines on COVID and SARS-2 infections. And this guideline, fellowship guideline making was given to Dr. Reba, and who's updated Dr. Aarti Kapil. So ma'am, would you like to update the House on the inputs from Dr. Reba, because she couldn't be part of this meeting today?
Yes, so I just briefly mention, I had a discussion with Dr. Reba. She's in USA right now, and she has given some points, and which also, I also agreed, I mean, both of us came to the same conclusion, that what is our basic purpose of this fellow? Is it a fellowship or is it a fellow of IMM? Because a fellow would be like an award, like a senior person, like somebody who's contributed significantly, then that is different. And if it is a fellowship for young researchers, where we would like them to take advantage of this fellowship to do work in an institute or some kind of a study or travel outside, we need money for this kind of a system. And some kind of, say, let's say accreditation or some, it should be acceptable when the students submit this at the end of their research program, that this is a fellowship of IAMM. I mean, it should carry some weight. It should have some kind of either accreditation or acceptance or recognition from a body. I don't know if IAMM per se can recognize this, and it is acceptable at the end of their term when they want to apply for a job. Will this be considered as a document worth consideration? But most important, those things can be taken care of. Most importantly, the point was we need some money for such kind of fellowship for a young researcher. So we need to, she said we need to make some kind of a smaller committee and subcommittee who will look into these aspects. What do we want? And one more thing, she said that pathology has an academy or something, but she discussed with the pathologist, there is no such kind of a fellowship. There is one fellowship of parasitology, but that is also award. That is a fellowship. It's an award. It's not a fellowship in terms of giving a researcher opportunity.
So we'll take this up in Agenda 12, which is already mentioned. I just wanted to give her input as part of completion of this agenda. So as part of Secretary's annual report, as I said, we are about approximately 4,000 members, 86 student and 43 annual members, and 183 life memberships were added this year. The annual conference at Bhubaneswar saw about 1,300 delegates and 600 abstracts. The PG Assembly, which was held at 4 centers this year after due diligence with the organizing committee sitting down and finalizing these centers. We finally had these, one at Jipmer with 27 students. Second was at Jodhpur, AIIMS Jodhpur with 24 students. And third one was IGMS Patna, 22 students, and AIIMS Delhi for 25 students. So this had an interesting mix of third year PGs and the faculty from there interacting with them, and a huge turnout. All the PG assemblies were extremely sold out, and all kinds of push and pulls were used to get students into this. So I think a huge round of applause for all the coordinators and the people who worked on this. Now we've added a new chapter this year, that is the Madhya Pradesh chapter, IMM MP chapter. But these are the chapters which were already existing, and they were very active. The annual conference was held at Delhi for IMM Delhi chapter. Then the MP MICROCON was organized, IMM KC. I could not get a report of Maharashtra MICROCON, but apparently they also held it in the last week of September. Then the Northwest chapter. And then the annual event, that is the sepsis webinar, held on 13th of September, saw about 1,274 participants, and with Dr. Chandvatal, Dr. Balaji and others participating as the faculty and the moderator. So PG Masterclass, we had 10 sessions. These were the 10 sessions, and I place and record my gratitude to all the speakers who spared their time to be with them. And these are the views and the YouTube views. They keep growing. This is still last night. So they keep growing. So the PG Masterclass can be accessed as YouTube channel, because we realize that many of the residents are traveling when we hold it at 6 p.m. Some are busy with their work, so they can watch it later on in the recording. The Zoom also has a limit of approximately 100 delegates only. We tried using other platforms also, but they are not very speaker friendly, so we switched back to Zoom. Currently it has 516 subscribers, and we have 1583 MD microbiology and 700 DNB microbiology seats per year. So you can imagine how many PGs and how many subscribers our channel can have. So I request all the residents, the junior faculty, anybody who wants to learn, to please go. These videos are either there in the video gallery or they are there in the live gallery. The ones which are live are streamed live on YouTube channel, so you can see it from there in case your Zoom is saying that you've exceeded the limit. Now I'll request Dr. Chand Vattal to please present the editor's report and the statement of the IJMM account. I will request somebody to propose. Dr. Malini is proposing it, and Dr. Ujjwala is seconded it. Okay. So it remains approved. Kya kar rahe ho? He is doing it from the remote thing.
So while they are just settling down, I have one small suggestion. Let us have a small SOP for how we conduct. Because over the years, as long as we have guidance for all our seniors, slowly, if it's a written SOP, it will be very easy. Thank you. Flow chart. Thank you.
Thank you, Dr. Sonal. With respect to the chair and the delegates over here and the EC members, this is a very brief report that I am going to present over here of Indian Journal of Medical Microbiology that I am actually handling at the moment. The major milestones that I need to share, probably this has come in the newsletter also, is the increase of impact factor from 0.8 to 1.6. Though the site score has become 2, significant decrease in turnaround time for publications, as Dr. Sonal already mentioned, and this by moving to continuous article publication method, immediate citation of the article on acceptance. So that is usually between 4 and 6 weeks, it gets online, and the online version message goes to the corresponding author. Waiving of author processing fees for better acceptability and affordability, increase in the number of issues in the year from 4 to 6, and we are already actually in the 2024 January, February issue is already online, and maybe in due course of time, maybe a year from here, we may go to a monthly issue. The way we are getting the manuscripts, but only is the acceptance issue. It's not moving. Major milestones that I can talk over here is the turnaround time of IJMM from loss-making to profit-making generating activity. Royalty obtained for IJMM for the year 2022 was around 10,000 euros, which is equivalent to around 9 lakh rupees. In the previous year was around 2.3 lakhs. So total up till now in these 2 years is 11 lakhs. So IJMM is now following the international research ethics guidelines. Now no article with an ethics statement is accepted for review at all, and whatever are the guidelines set by Alzheimer's, and we have tailored it for our purposes, gets into peer review unless that is followed. There is, even if a bracket is missing, it is being sent back to the author to have it corrected, then only the review starts. The desk audit is around 40%, rejection is 40% at desks, so that the reviewers who get the articles are already cured and they can feel like actually reviewing it. The above improvements has led to the increase in the number of submissions, especially from outside India, highlighting its growing popularity and visibility among the nationals and international researchers. We have just reached US shores, but we are in the Europe as on today. Though we're getting in huge articles from Iran and we're getting inundated with them, many times we have a problem in getting the veracity for them. So I have addition of 2 associate editors, taking total to 5, and it has been an excellent find as far as we are concerned. I have Dr. Kavita Raja from Kerala and Dr. Kalita from Assam. This actually completes my research for the talented associate editors missing from Deep South and Northeast, completing my team representing the country to the satisfaction of all the IIM members. And this is shown up by the type of articles that have started flowing from Deep South and from Northeast. It has already shown an increasing trend. So we need to repeat this as many times as possible as to how to reach the journal, because our website, My IIM, is not actually having the hits from our members. That is the bottleneck why we are not able to reach the IJMM. Many authors do call me that we are not able to reach to our own article. We are not able to share it, and we are not able to see the whole volume. So the only thing is that they are not listening to whatever newsletter says and whatever the website says. So they are not into that kind of an activity. So people need to go to My IIMM, and that is how the flip side for this is you have to activate your free IIM membership through an IIM official website. Please go there, update your profile, generate your password from there. The activation are also outlined in the newsletter. I think Dr. Sonal has kept the newsletter here as well, which has, or it was circulated earlier, which gives you all these steps over there. This is the IIMM, this My IIM website. Once you go there, you will have join IIMM or member login. If you are already a member, you know your password. Kindly go to the member login. You will reach there where you want to. You will reach your profile. You can edit it. Or if you are a new member, then you join IIMM, and this is the profile that you may reach into. And in this, once you say that you are a member, you can see there is something like Journal IJMM. There is a Journal IIMM over there. Once you click on that, it will tell you to wait for 5 seconds. And after that 5 seconds, there is a link that will appear, and it will say click here. And once you click over there, you will reach the home page of IJMM. We are also already planning to put a logo over here with the link, so you can also go to the web from the home page to the journal directly, or to the website. If you are not a member, you can go to the My IIM website. That link as special issues, because many journals do produce special issues, and we're planning for 23-24, and very grateful to my guest editors, Dr. V. Balaji, Dr. Pallav Ray, and Dr. Shiv Prakash Rudramurthy, who very readily agreed to do that. Of you in 2023 year to end, published from 2021. We have Dr. Purva Mathurs as topping the list in 2021, Mycoplasma hominis, Dr. Binu Diwan, then rhinocerebral mucormycosis in COVID-19 from Nehru Kapoor, then basic virology, SARS-CoV, Panda Pragyan, and I think you can all read this, and this is and Kusum Sharma from PGI. She has written on mycobacterium.
request I have for you. Please send an email regarding all steps of which you show for every member. What is the route of getting IGMM article? Because I can't.
You see, I get so many calls from many of you, and I keep on telling you that
But
the
sir,
newsletter is in your mailbox.
So,
So-
no, sir. But from my IIM site, I can't get anything, sir.
You cannot get anything because
Yeah,
have you registered
beside
there?
my profile?
Have you changed your profile?
No, same.
It's the same.
Same.
See, this is
If it's taking you on the profile, then is it not moving? What does it say?
No, on my profile, if on member login, if I've entered my name, so there is my name, and
That is
but
in the directory.
I can't get any article or any other thing. I
no,
can't.
you will not
do-
get you will not get anything automatically. You see, it
So
doesn't
that's
function.
why I'm telling you, please send an email regarding all steps.
There are
How can I
3,000
get that article? Because our PGs not
this
PGs
is-
do not get any article from IJMM.
You see, we have 3,600 odd members,
Definitely.
and there is no
Can
permanent staff on
can I
IAMM.
give you my email ID?
Perfectly
then please
fine,
Send me
perfectly fine.
Just एक minute.
आप बताइए.
मैं बताती हूँ. The steps are outlined in the newsletter. The newsletter is uploaded on my IMM website in the newsletter tab. Second way is that where you go for member login, there the steps are, the pictures are pasted there on that. So if you go on the newsletter, you can check it there. If you go on the website and you go for member login, there is a box where you are saying your name comes, no, the directory. On the right hand side, there is a box which says click here to how to activate your membership. Only when you activate your membership, you will be able to go to IJMM. Because your 3,800 members, this association runs from the time where there were no members, there were no emails. So those emails have not been updated by the members. That is why this step is necessary. So that your email gets, once your email gets updated in the system, then you are able to do that. Then send a mail to the website manager. He will activate your membership backend. Then it will take you to IJMM. These steps are pasted on the website as well as in the newsletter. You can pick up a copy here. नहीं चल रहा भाई. हाँ चला. सर आ तो जाऊं उसमें. The IJMM editor report proposed by Dr. Chakrabarti, seconded by Dr. Rakesh. So we now move to next agenda, that is presentation of annual statement of IMM accounts by treasurer. So I request Dr. Manoj Kumar. अब चेंज मत करना, यही चलनी है, बाद में चेंज होगी तब बता दूँ.
नमस्कार. हम हिंदी में आपको बताएंगे ऑडिट रिपोर्ट. तो अगर किन्हीं को दिक्कत होगा तो हमसे बाद में पूछ लेंगे. ये हमारा सेविंग अकाउंट्स डिटेल्स है और एट प्रेजेंट हमारे पास सेविंग अकाउंट्स में 26,49,643 रुपये हैं. 26,49,643 rupees in saving accounts. फाइनेंशियल ईयर दैट इज द फाइनेंशियल ईयर जो था हमारा 31 मार्च था, उसमें हमारे पास पैसे थे 21,49,882, 21,49,812 रुपीज़. ये इंक्रीज हमारा हुआ है, दैट इज़ ड्यू टू ये मेंबरशिप फी की वजह से हुआ है. पिछले साल हमने रिक्वेस्ट किया था उड़ीसा चैप्टर को, जहाँ पर कि उड़ीसा में कॉन्फ्रेंसेज हुआ था। हमने वो बोला था डॉक्टर चैनी को कि यू टू गिव द सम मनी, हमें मनी जो आईएमएम को देना होता देने के लिए। तो बोली थी क्या कि हम कॉन्फ्रेंसेज में आएंगे और यहीं पे चेक देंगे, और आज वो फाइनल की कि हम 5 लाख रुपए आपको मंडे को भेज रहे हैं। तो थैंक टू उड़ीसा चैप्टर एंड पार्टिकुलरली टू डॉक्टर चैनी कि वो 5 लाख रुपए देने के लिए एग्रीड हुई हैं। उनके पास पैसे काफ़ी कम बचे हुए हैं, इसीलिए उन्होंने जाके 5 लाख रुपए दिया। हम उम्मीद करते हैं कि लखनऊ कॉन्फ्रेंस से ज़्यादा पैसे मिलेंगे, क्योंकि इनको बहुत ज़्यादा फाइनेंस हुआ है, तो कम से कम 10 लाख रुपए देंगी। ठीक है, ठीक है। थैंक यू। ठीक है, नेक्स्ट स्लाइड। ये हमारा फिक्स डिपॉजिट अमाउंट है, जो हमारा फिक्स डिपॉजिट अमाउंट है, जो अभी 1,80,77,194 मीन्स दैट 1,80,77,194। ये दिस द फिक्स डिपॉजिट। एंड टोटल रेवेन्यू जो हमारे गेन हुआ है इस ईयर में, जो 22-23 में, रेवेन्यू फ्रॉम द मेंबरशिप ही 9,13,025 रुपीज़। रेवेन्यू फ्रॉम इंटरेस्ट, इंटरेस्ट मीन्स दैट द सेविंग और द करके जो हमारा फिक्स डिपॉजिट है दोनों से आया, वो 15,43,529 रुपये, 15,43,529 रुपीज़। सो टोटल profit revenue gain, that is 24,56,554 rupees. This is the income and expenditure of the financial year, that is 2022 to 2023. एंड ये बैलेंस शीट है। बैलेंस शीट में आपको नीचे में अमाउंट ज़्यादा दिखेंगे, ये हमारे पहले का प्रॉब्लम है, वो प्रॉब्लम चलते रहेगा। हम ट्रेजरर रहें या कोई भी ट्रेजरर रहें, सबके साथ ये प्रॉब्लम रहेगा, क्योंकि हमारा पहले वाला अकाउंट बहुत ज़्यादा जो पहले थे जहाँ जहाँ, वहाँ से अकाउंट में कुछ कुछ पैसे वो दिखते रहते हैं, तो वो चलता रहेगा। ये ट्रेजरर ख़त्म नहीं कर सकता है, बहुत मुश्किल है। क्योंकि मैंने सबको कॉल करके बोला कि भैया पहले वाले आप हिसाब क्लियर करके दें, तो किन्हीं के पास कोई रिकॉर्ड ही नहीं है, तो इसलिए ये चलते रहेगा। लेकिन एक्चुअल फिगर हमारे पास जो पैसे हैं, वो टोटल फिक्स डिपॉजिट और जो सेविंग में है, वो मिला करके हमारे पास 2,05,33,748 मतलब 2,05,33,748 रुपीज़ हमारे पास हैं, जो अभी एट प्रेजेंट में। सो ये 2,82,82 जो दिखते हैं, ये गलत दिखते हैं, ये सही नहीं हो सकता है। एंड दिस द कॉपी ऑफ द रिटर्न एक्नॉलेजमेंट। और मेंबरशिप जो एनुअल मेंबरशिप जो होते हैं हमारे पास में 2023-24 में, लाइफ मेंबरशिप दैट इज द न्यूली एडेड दैट इज द 183, एनुअल मेंबरशिप 44 एंड स्टूडेंट मेंबरशिप 82। सो टोटल मेंबरशिप till this date, that is 3,838, that is life membership. Thank you. नहीं सर,
your yearly expenditure is not more than 5 lakhs.
सर।
तो वो जो 21 लाख को आप फिक्स डिपॉजिट
अभी जस्ट जाके कर देंगे सर। हमने ये सोचा था सर कि पिछले साल जो बात चल रही थी कि कहीं पे बिल्डिंग्स लेने हैं, कुछ करने, जमीन देखने हैं,
चलो
वो
जो भी है,
इसी वजह से नहीं किया था सर।
तोड़ के भी किया जा सकता है, अदरवाइज वेस्ट हो जाता है
सर। अभी जस्ट जाके फिक्स कर देंगे सर।
अच्छा, दूसरी बात जो मैं ये सोच रहा था, मैं पीछे भी बोला था मीटिंग में, जे हम लोग एक कोशिश करते हैं इसको इनकम टैक्स फ्री कराने के लिए, क्योंकि 6 ऑर्गेनाइजेशन इनकम टैक्स फ्री हो गया, हमारा फंगल इन्फेक्शन स्टडी फोरम भी इनकम टैक्स फ्री हो गया। वाई यू पीपल आर नॉट ट्राइंग टू मेक इट इनकम टैक्स फ्री IMM? बिकॉज दैट इज ओनली थिंग इज दैट जितना आपका एनुअल इनकम होगा उसका 80% आपका खर्चा करने पड़ेगा। बट दिस इज ए गुड थिंग, खर्चा अच्छा कम में करेंगे। तो ये बात जो है ना, नेक्स्ट यू आर गोइंग, नेक्स्ट जो ट्रेजरर आ रहा है इसके बारे में स्पेशली डॉक्टर शिव प्रकाश से बात करें, क्योंकि अभी वो हमारा फंगल इन्फेक्शन स्टडी फोरम की टैक्स फ्री कराया और सीड्स का जो है जॉर्ज वार्गीज इज़ वेरी एक्सपर्ट इन दिस, उससे ही हम सीखा है, वो भी करें क्योंकि इतना साल हो गया हम क्यों नहीं कराए, अब शुरू करते हैं। ये 3 साल लगता है बट ये कर सकते हैं।
सर पहले जीएसटी जाती थी हमारी, जीएसटी को हमने बंद कर दिया क्योंकि 30 लाख से ज़्यादा हमारी इनकम से है नहीं, तो जीएसटी से काफ़ी पैसे हमारे सेव हुए हैं सर। पहले ये
ठीक है, मैं आपका बट ये जो है इनकम टैक्स भी सेव हो जाए तो दैट वुड बी द बेस्ट थिंग।
एक्सपेंडिचर नहीं है सर, तो एक बार सीए से बात करते हैं इस साल जो करना है हमें ना सर। तो
प्लीज ये शिवा से बात कर लीजिए क्योंकि हमें ये शिक्षा मिला था सीट से
सर।
सीट से ये भी दिलीप मथाई सिखाए थे, तो दिलीप मथाई से हम सीखे एंड उसके बाद ये है, ये सिस्टम देख लीजिए।
सर थैंक यू।
Sir, if you remember, we were trying to get into the Constitution. This was the reason. We did not have a copy of the Constitution. And the certificate we did not have. The task was given to me to fish that out in Delhi because it was framed in Delhi. I managed to get that and I gave it to the office bearers. The records are there. I think Dr. Sherwal will bear me out, but there is a glaring gap in there. When I went to the registrar societies, that woman told me, who was an IAS, Dr. Vatal, what are you trying to do here? I will disqualify it right now. I said, why? She said, there is hardly any copy of the GBM minutes from the last 5 years. And if I show you, there is only this file. There is nothing inside it. So no minutes of GBM has gone to the registrar societies to keep your society alive. So we have to be very careful in getting over there. Either we go there and give them all those minutes and put them in record and then take up this step.
Give the previous 5 years copy of the newsletter which has the minutes.
थैंक यू।
So if there are no issues, can it be proposed by somebody? And proposed by Dr. Saeed and seconded by Dr. Sherwal. So moving next, report of the coordinating EQUAS South Center as well as North Center. So we can first have, I think, sir, आपकी PPT अलग है, sir, Dr. Vatal? EQUAS report, North Center, or we'll finish with the South ones because it's here only. All right, all right. So can I please request Dr. Rajesh for virology EQUAS and followed by Dr. Balaji and then Dr. Vatal.
Good afternoon, everyone. I thank IMM for giving this opportunity to present the report for the virology EQUAS from South 2022. These are the people involved with the program of the virology EQUAS. And we got the first accreditation in 2019 and re-accreditation in 2022, and we are going for the re-accreditation again in 2024. These are the participants over the years from 2017. It is gradually increasing for serology, and majority of the participants are for the BBVS, bloodborne virus screening, followed by dengue. And the molecular panels, again, the participants showed a gradual increase from 2017. And currently there are about 350 labs participating in molecular alone, and of which HCV is the highest number. And this is the participant distribution across the country, and currently there are 1,009 laboratories participating in the virology EQUAS program from South. This is the concordant results that we obtained during the 2022 cycle for BBVS. All the time the concordance was above 90%, and for dengue it is from 70 to 98%. Same way for HBV serology, again from almost above 80 to 100% concordance showed during the last year cycles. And for AHS panel, again, that is a HAV, HEV, and IgM core for HPV, again showed a very good concordance above 90%. And the immunoscreen also showed a very good concordance. And for the molecular, HIV RNA showed more than 85% of the participants showed 0.5 log within difference. Same way HBV again, the concordance was more than 85%. HCV also showed a good concordance, and CMV also showed more than 90% concordance. And the molecular CS of meningitis panel also showed, most of the time it showed a very good concordance above 90%. Certain times it's gone below 70%. Respiratory again showed more than 70%, and dengue RNA also showed more than 95% concordance. And if you take the number of participants which gave 100% concordance in all the 3 cycles, it was 82% for the BBBS panel. And if you take more than 90% concordance, it's more than 99% of the laboratory in the country are performing very well. And that for dengue is about 82% if you take more than 90% concordance. And for HBV serology, again, it's about 93%. And for AHS panel, again, 92%. And the molecular we already mentioned. And for the respiratory panel, again, 76% of the laboratory showed more than 90% concordance during the last 2 cycles. We also obtained feedback from all the participants, and most of the are very encouraging. And one of the major issues actually, at least 2% of the participants is asking for more sample volume. That is one area actually we are also trying to improve it, because getting positive samples with the high volume is a very difficult thing. But still we are trying to increase the volume of samples wherever the participants have requested, especially for BBBS, HBV serology, as well as dengue. And in the coming years, what we feel is there can be some difficulty in getting a PT material, because if you look at, it's very difficult to get a HCV RNA positive sample as well as HIV RNA positive sample, because most of the patients are on treatment and viral load will be undetectable. So in order to get PT material for at least for those 2 markers is going to be difficult in the coming years. So we have to find some alternative mechanism to get the PT material. So like replication system for hepatitis B and C, as well as culture for HIV and dengue. And this is the contact details, and thanking everybody who has helped out with our program. Thank you.
Oh, there, okay. I think I can present. Good afternoon, everyone. In the first place, I would like to thank IMM for giving opportunity to conduct proficiency challenging test challenge from CMC Vellore. In short, I would like to recall what I have included in the PowerPoint. The first and foremost, I am very happy and proud to inform the gathering that recently we had a publication from ASM journal, JCM, where they did a survey on College of American Pathologists accredited labs, how they are giving bacteriological identification and susceptibility report. And in US, currently, the CAP accredited 40% of the labs are giving, 70% of the labs are giving error reports. And 40% of the CAP accredited labs outside US are giving error reports. To this, comparing to this, I had an opportunity to compare both these results. In bacteriology from India, for identification and susceptibility reporting is almost 98 or 99%. So it was really very exciting to see that the microbiology, bacteriology labs across the country, from the primary health centers to the secondary tertiary care, they are doing an excellent job. And especially, I was wondering why such a difference is there from the West to our country, even North America and Europe. I feel that they are more dependence on the automation is there, and they don't think, just they give. Whereas here, majority of our labs are not automated, manually they are doing it. And in timely, people are aware of the guideline changes. Because now every state has got a WhatsApp group, and they disseminate. So almost in real time, everybody gets the new information and they implement it. So even we are circulating anything new, lessons learned immediately. So they are quite aware, and I was very happy that it's doing very well. So we are moving to the next level, where we don't want to repeatedly keep giving only Staph aureus, Enterococcus, escape pathogens, Salmonella, Shigella, because last 7-10 years the same organisms are being repeated. We want to go one level higher and try with the fastidious organisms, especially vaccine-preventable infectious diseases like pneumo, H. influenza, meningococcus, diphtheria, pertussis. So we have sent a circular to all the centers informing that we are sending little next level high-risk pathogens, which they need to handle it carefully, discard it carefully. So that's what we were expecting. We have informed them, primed them earlier, and we are planning to challenge with, already we have started, and we are trying to challenge with the fastidious organism. Because same repeated, because diphtheria is common now, and we want people to get used to the fastidious organism. That's one. And in the coming year, what we are proposing is, we wish to add to that list Clostridium difficile, Helicobacter, and Campylobacter, because with the changing times, we are not going to see much of an Shigella or non-typhoidal Salmonella. More of a Campylobacter, Clostridium is so common, we are not failing to pick it up. So we thought that we will move to the next stage. And one new additional information which I would like to add, which I have not given here, is and 1,125 labs are participating with us. And MR, and people to take a population analysis profile is also continue to do the same. If at all we have little problem, only of the 1,000 labs, 3 are mere scoring, because we always try to if we make 100 smears, 30 smears are checked by our own people. If consistency is there, then we release the batch. such a extra effort to take for this year. And it is quite challenging, and most labs, they get back to us, we appreciate them for getting back with us, because no, they are so concerned about getting good marks, 100 out of 100. Every lab is very clear. But I'm telling you, even though we give scores, at the finally, yearly, we are not going to give the score on the certificate. Just for the participation we do. So the intention in this program is learn from each other. So it's not the scoring. So once again, I want to tell that if you have learned something from this, or we have learned, we are more happy than the numbers of that score. Because nowhere in the certificate we are mentioning about the score. And you can see consistently year after year, the numbers of participants are doing very well. Only the smear, there will be a problem, not with the culture. It's all 100% correlation. And serology also almost 100% correlation is seen. So it's only the smear, but still, if it is a culture smear, we will get 100%. But we don't want them to subject our time and effort based on the culture smear. And here, what I would like to add, one important information is when they are enrolling for EQUAS payment in the beginning, all the private institution pays the GST. And all the government institution, they don't pay the GST because the government exempts from them. But recently, 1 week back, I received a circular from Government of India saying that year after, even the government institution has to pay GST. So it's going to be from 2024 onwards, the GST is applicable for all the non-governmental and the governmental institution. So this is the new information. And the Department of Microbiology for antimicrobial stewardship and quality control, we are chosen as ICMR Collaborating Center for Excellence. Then this is the contact details, and I would like to thank my team who helped me with this. Thank you.
Thank you, Balaji. By the time I get my slides, I actually resonate the similar sentiments what Balaji said as far as the serology as well as the, and Rajesh also talked of serology. So both I resonate the similar sentiments, and we also having a kind of a growth that we are talking about is it in this presentation? And most of the labs, my only concern is that we are not having very big numbers as far as EQUAS is concerned. So to derive very direct inferences may not be always carried well. So that is the main issue. So though we have grown from 200 odd centers that was shifted to us from Shankar Netralaya to around 787. So that kind of a growth is over there, and most of these are the NABH accredited labs. And these labs are actually are participating. The smears, of course, is the sore part of the whole scenario.
file corrupted hai.
Corrupted hai. So some file corruption is over there. So by and large, the highlight of our center as on today is after having achieved around 787 centers on board, we did try and go into the tier 2, that is to start the molecular EQUAS. And the molecular, the slides are not there because there is some corruption in the file. So I have given my pen drive, so I hope they are able to retrieve it. So the molecular EQUAS is the one that we have started. From the first QC has gone, and we did circulate a Google Sheet to all our participants, and इसको यूज़ ही नहीं करूँगा. लेकिन ये कर्सर नहीं मूव कर रहा भाई इसका। यहाँ आप या तो वहाँ छोड़िए नीचे, अरे इसको करिए ना।
अच्छा स्लाइड शो करना है
हाँ जी,
वहाँ से करेगा।
इसने वहाँ पे कंट्रोल लिया हुआ है। So I will show you the response that from participants on our Google Sheet, and on the basis of that we found out as to what is viable, which we can start. अभी कुछ चल तो रहा है। अभी सारा ठीक था। फॉरवर्ड कौन सा है? So this over here, and humble staff for this activity, and we have our esteemed panel of advisors in which Dr. Wal is there, Dr. Ganguly, Dr. Broor, Dr. Archana Ayagiri, and the full-time statistician. चल रहा है? नहीं चल रहा? बंद कर दो ना। We did not get very healthy numbers, but somehow the 5 analytes that we tried to do on molecular EQUAS was the quantitative for HIV, HBV, and HCV, and similarly we did for CMV quantitative, because the renal transplant is active in the country. And anyway, I'll skip these slides, though I did show you that this is 787 that we have reached over here, and across, and analysis has been the similar. I will skip this, whatever Dr. Balaji has said. It is a similar kind of a experience that our center also is having, and the satisfaction is that most of the scores are very good as far as the serology and the culture reports are concerned. We got re-accredited very recently, and in 2023. This will be for 2025. The certificate is in process. They wanted to pay upfront before they would send the certificate, so that is in process. And this is the Zoom meeting that we have with the participants. This has been done in last year. And this is the packaging advancements which we have actually done because of the analytes that we are sending separately, and these have been actually taken over from the CMC Velour, and we changed from the cardboard to the plastic ones that are better, and the breakage rate is much less. And I think this was already put in the newsletter for that our lab, EQUAS lab, got the SK Joshi Lab Excellence Award last year. And this is the website interface with the participants. We have gone totally paperless. Only the challenge is being sent by courier. Rest nothing else goes by courier now. And you have online submission of the results. There's a reduced turnaround time and reduced courier expenses. No lost delayed results due to courier issues. Login and password of each center is confidential, as well as the data is confidential. They can have the facility of archival of their reports. They can generate their own report, and this is the feedback that we send them. And they can download a certificate like this at the end of the cycle. So this is what I was talking about, the EQUAS New Delhi team, which we started this year. And this was the response from the participants. 128 responses came back. And on the basis of that, the viability of these 5 analytes could be added. and it included the TB molecular test. And the first QC of June, we had very modest numbers. You can see only 24 for HCV, and by and large, the results were quite good from the participants, on 15 from HBV, and only one center that came forward for 6 centers that came forward for HIV. And for CMV, there were only 4. We expected more because of the, we thought that renal transplant in North and Northeast is actively going on. But this is the first cycle only. We are only expecting it to increase. The MTB response, though, should have been better than this, but somehow it is around 25 centers have participated. The audited statements have been submitted to the Secretary and are available here on the podium. You are welcome to see that. Thank you very much.
Any issues with
say
this?
something?
Yes, ma'am.
Thank you for the presentation on quality control. So just want to add that one of the branch which has been neglected in quality control and EQUAS is anaerobes or anaerobic strains. So we are starting Anaerobic Society of India, which is all the legal formalities have been done. And we also have Dr. Nagy, she's the editor of Anaerobe Journal here. So we started the first as a pilot project. I did write to that time IMM president showing our interest in starting EQUAS for anaerobes only. And from AIMS that time we have sent the strains to Chandigarh. Dr. Archana is looking after that, Dr. Padmaja in Mangalore, Manipal, and Dr. Beena, Mangalore, Dr. Shashwati from AIMS Bhopal, and also Dr. Surujna in AIMS Bhubaneswar. So I requested that time any organization, any institute who are interested in getting those strains can be in touch. And right now, Dr. Nishant and Dr. Tanu are looking after anaerobic section at AIMS after I superannuated. So I just wanted to convey that we have a lot of interest in that. And those people who are interested can be in touch with me or Dr. Beena to carry on this EQUAS on, specifically on anaerobes. Including, see, difficile, Dr. Bala has just mentioned that they are including it in their GI panel. That will be also included in that. Thank you for that.
Thank you, ma'am, for the information. Mic, ma'am.
I just wanted to ask for both the team, excellent work. You're doing regarding, especially for government institutes like us, to avail to the PT which you all send. What about sequencing? Are you all thinking in the near future? Because everybody is now taking sequencing in the diagnostic mode, and changing therapy, especially in the private sector. So I just wanted to know, because when the reports come, especially for TB, when they are now taking it for treatment, is there a scope? Because we are very, from the program aspect, we're a little worried how valid are these sequencing reports which are coming in? Because there's nothing like a quality assurance in that. So is there a PT thought about with the IMM team?
Yeah, for TB that we have started, we just begun. And once we...
Yeah, I saw that. That's why I was wondering whether you are even thinking of that.
Maybe in the future we can look into this option.
In the future we may look into that.
So the EQUAS report needs approval. So it is proposed by Dr. Ravi and seconded by Dr. Amita. So moving on to the next agenda, selection of the topics. The EC deliberated a lot of topics yesterday, and we finalized that for IMM symposium, artificial intelligence in microbiology, as it is a very upcoming topic, to be moderated by Dr. Balaji, or vaccines now and then, the moderator would be Dr. Neelima Hirani. So I would like the opinion of the House as to which to go about with. AI. AI. Those in favor of AI? Oh yes, overwhelmingly it wins. So Dr. Balaji would be the moderator for this session. Yes, if there are any other topics, if anybody.
Showing it is the 46th, MacroCon. Actually, it should be 47th MacroCon because during 2020, we have already conducted MacroCon, which was a e-MacroCon. It was very well conceptuated by the EC of the IMM. President Dr. Pallav is there, and full accept the prizes. Everything was done, and all lectures, all 3 days were meticulously planned, and Dr. Sonal and Dr. Vatal was the chair, I think, that time, and Dr. Sonal organized. It was one of the excellent conference during the time when we were all into pain. So I think that when I was seeing the record, it is not put on a record anywhere. So we are missing it. It is an IMM activity, so it should be put on record. So it need to be rectified, and so the next time it should be 48th, and then Dr. Vatal, your conference should be 49, and then we are looking for a mega place for the Golden Jubilee Conference. I think there should be a bidding for a very good place, whatever.
Sir, is it okay to change the numbers now, because now it will show a missing number for this year?
No,
because
it
website
be,
and every place.
As far as we can adopt here, and it can be for all official purposes, numbering can be changed, put on record.
सर एक रिक्वेस्ट होगा कि 50वां जो करेंगे ये कोई अच्छा जगह अगर करना चाहते हैं तो इसी करे कॉन्फ्रेंस अपना ही करे, और गोवा या केरल कहीं करें सर, हम लोग कर सकते हैं जाकर के, कोई दिक्कत नहीं है
सर for the 2020, it was the pandemic. Because of that, we conducted the e-microcon. But at that moment of time, by EC as well as in GB, it was decided, because there was no presidential oration as well as other activities of IMM were involved in e-microcon, we will keep that 2020 activity as a e-microcon only. Because of that, the number was not been given to that microcon. It was a e-microcon, and no presidential oration and no activities were. But sir, but that time we decided in. Yes, sir.
So, by a show of hands, can we have how many are in favor of changing this number and putting that e-microcon as a conference? No. So we just put e-microcon there and the numbering continues.
No, numbering should
All right.
continue at 47. This should be considered. It should not be changed. E-microcon can be recorded that e-microcon was
All right. So instead of in 2022, this time also the organizers asked me what we should put there, and the status was fluid, so that's why. So it is now recorded that it is an e-microcon in 2020, and we will continue the numbering as 47th will be next year then. All right. Thank you, sir. Sir, 2024 will be 47th, 25 will be 48th, 26th will be 49, and 27th will be 50th. So it will continue like this. That's what the House feels, sir. So is this agenda considered approved? Can it be proposed by somebody? So proposed by Dr. Patil, seconded by Colonel Nagendra.
Madam.
Yes, ma'am. Sir, that we can take for next year, sir. The majority of you felt that it is a congress and not a conference. So from next year, I have already told Dr. Rajesh Karekarte, and he's changed it on his website as Indian Congress. Yes, ma'am.
Madam, I'm Dr. Meena Mishra. I'm professor and head from AIIMS Nagpur, and we had presented this bid for the year 2026. But I would really request all of you to consider this, because AIIMS Nagpur, it has a wonderful venue for conference and state-of-art facilities. So, like if we get a green signal, we would like to.
We usually, ma'am, we usually take this decision 2 years in advance. It is there, sir. It is recorded and minuted that you have an intent to hold it in 2026.
Yes.
The decision will be taken next year.
Acha, okay. Thank you. Thank you, madam. Thank you so much.
So there were various awards which had to be decided. So for the UC Chaturvedi Lifetime Achievement Award, Dr. V.L. Jagirdar has been awarded this prestigious award. After a lot of deliberations, the EC evaluated all the candidates and came to conclusion that Dr. S.C. Agarwal Oration be awarded to Dr. Chand Wattal for his exemplary services. Dr. H.I. Jhala Award for the next year be awarded to Dr. Pallab Ray. And the IIMM Endowment Oration Award be awarded to Dr. Jayanti Shastri. Congratulations to all senior members. So, is this agenda taken for approval? Yes. So, election of office bearers, the president and the treasurer, because the treasurer completes the term this year, plus there are 2 vacancies of executive council which will be advertised in the newsletter for January 2023. So, president, Dr. Bharti Malhotra from SMS Jaipur, the EC members feel. Congratulations, ma'am. And for treasurer, Dr. Sheila Devi from Pondicherry. who served earlier as an executive member. Congratulations, Dr. Sheila. So is this agenda taken for approval? Proposed? Dr. Mishra and Dr. Yogesh. Dr. Sanjay, you've noted? सर अब मैं सब में कर रही हूँ सर ये भी तो इसी से आया ना इसलिए नहीं है ओके
सर फ्लो चार्ट बनाएंगे फ्लो
चार्ट बना लेंगे सर अब नेक्स्ट टाइम So this was the agenda number 12, their proposal or suggestions regarding trainee program, PG Assembly and IJMM PG Masterclass. This proposal I have, like we've started the PG Masterclass, I felt we should have more of academic pursuits and we thought two ways we can do it. One, we start a certificate course and the other, we start training courses at least 2 to 3 per year. We all do it under our chapter activities, but can we do it under the aegis of IAMM banner, where there were 3-4 suggestions which came up. One was on HUNET workshop for 2 to 3 days for our young microbiologists, antibiogram making and using them for our younger faculty members who are involved in AST reporting and surveillance, and for molecular diagnostics. So anybody who would like to hold these can have it under the aegis of IAMM. And we would do it under the governance, we will work out the modalities. For IMM certificate course, I request the GB to please give suggestions on this. The EC members felt and we all decided that there should be a 6-member committee, the names of the members are there to explore these modalities. But what the basis is, I will talk about it. It's a certificate course which will be, आगे करिए please. Which will be signed by the core group of IAMM and it will take 12 to 16 students in a hybrid mode. Any MD or DNB student, second year onwards, so that they have some basic knowledge of whatever course this is. This could be an antimicrobial stewardship, this could be in infection prevention and control. The course program will be delivered in an asynchronous mode in an online way with a contact session at the end. It will be a practically oriented modules will be there, where very little didactic teaching will be there and the fellows will be teaching one another. So it will have an on-site and an online component. The duration would be for about 6 months in 12 to 15 modules with an on-site appearance for about a week, which will include the assessment as well as the practical, something like an OSPE with a practical component and also some training which requires practical input. So if the house approves, then we can take this as a method, or if it's open to suggestions. We have spoken to people from critical care medicine and the Association of Anesthesiologists who have been running these courses for them. Very often what happens is our students, when they go out for a particular thing, say a molecular diagnostic lab or for infection control officers, they are asked to produce some certificate course which they have undergone. So instead of relying on a private body, why not our own association start this so that we give some credit to the students who take this effort. Sorry.
So maybe we can meet once, I mean, if it's generally in principle acceptable, then the finer working of this system can be discussed in a smaller core
Yes,
group
ma'am.
meeting.
I've made that small group.
So
I've recommended these names.
If in principle, okay, then of course we work out how does it work and how does it gain acceptance.
Hanji? Let the committee will finalize the modalities. We'll have online meetings and the committee will finalize these issues.
Okay.
Sir, पहले committee बीच में कर लेगी so that we can start from next year. मतलब end of either just after the next conference we are able in a position to start it. Now, any other matter? There was one request put up from IJMM. to EC that the EC recommended that there should be a core group of 4 senior faculty of IIMM, which can give names of 10 high quality reviewers for editors' use. This is an attempt to increase the impact factor and also create possibility of fast tracking articles, because they are now being published as soon as accepted, but they can't be accepted unless they have been peer reviewed. So one suggestion was this, and the other suggestion was that all the EC members should assist in these journal activities and should actively participate as reviewers. So if it's okay with this, or any other suggestion if anybody has. Yes, ma'am. Mic, please.
Ma'am, actually, what I would like to say is that we are reviewing foreign journals like Frontiers, then Scientific Reports and others. But IJMM, I'm also like doing for IJMR, but IJMM has never approached. So is there a mechanism by which we can at least say that we are already
I think
reviewing?
we can write a mail. Anybody who's interested.
Please send me a mail. I will be very pleased.
Sure, because that's one thing which I thought I should suggest.
And I think we choose to encourage this method in our departments also to
Yes,
other
ma'am.
faculty
Actually,
members.
there are other faculty members who also want to be reviewers.
Yes.
So we can suggest.
I think we can increase the database. The problem is it's somewhere stagnant. So if you please write, it is more than welcome.
So there was another plan was that the NMC bill, which was introduced and later withdrawn or kept in abeyance for some time by NMC, if that comes the association will have to make a contingency plan as to how to run the conference, whether to increase the registration amount, do away with the freebies, and manage it at an institutional level only once a year, because we cannot have our existence without our MICROCON. So for that, if anyone has any suggestions, please put it up, and I request the senior past presidents, Dr. Chakrabarti and Dr. Ravi, to please suggest whatever you suggested. I put it up, but to suggest and come out with more solutions to solve that issue, because if we are not allowed to take any more sponsorships or any diagnostic these things, then it will become an issue. So if anyone has suggestion, please mail it to me so that we can include it in this meeting. The other, I request that 10% of the registration fees that is charged by the MICROCON should be given to IIMM, at least, if not less. So this, the EC member, we had a lot of discussion and a lot of arguments both ways. So we would like to inform the House that this is what we decided. So if this should be implemented from this year, suppose the registration, average registration for this conference was 10,000, then 1,000 from that should come to IIMM. So the total number of registrants that you had.
Just quickly, the thing is that these proposals, yesterday I tried and with Dr. Ravi to discuss with the EC certain things, like suppose this time NMC bill came that you cannot have any of the sponsorship. And all those, then how the conference to organize. So we have given some idea, like suppose wherever the conference should be planned in the city, there should be some institution should have the hall, so that we can, at a lower budget, we can have it. We can have the, like suppose we discussed how anatomy organizes the conference, how forensic medicine organizes the conference. They don't have any sponsorship. So those are the things we discussed about it. I think that it would be crystallized to a certain extent. We are discussing this aspect. Anybody has any idea, please give it to EC. That would be very useful. But this particular issue of 10% registration fee we thought about, because we need to increase the kitty of the IMM. If IMM has got more money, at present we have got 2.6 crore rupees. If we have more money, then there would be more interest comes out of it. So that can be given for the conference to organize. So that's the reason we were trying to have, because today it had been withdrawn, but tomorrow it would come, NMC bill. So that's the reason we thought about it. And this is the main decision you have to take here, that next year onwards, 10% registration fee to be given to IMM.
This year onwards, sir.
This
year.
Acha, this year onwards. Acha.
This year onwards, sir. See, भुवनेश्वर could give 5 lakhs. सर देखिए, भुवनेश्वर अगर 5 लाख दे सकता था तो आपसे तो हम वैसे ही 15 लाख की उम्मीद कर रहे हैं, वो तो 10% से कम नहीं होगा.
हमने IIMM से इनिशिएट करने के लिए कोई पैसा नहीं लिया इस बार.
10% registration fee, 10% of the paid registration fee.
हाँ, हाँ, the registration fee that has been paid, obviously, of the total number of delegates.
मैम अगर पहले से पता होता तो हम लोग उसी हिसाब से रजिस्ट्रेशन फी.
नहीं अभी नहीं डॉक्टर, अभी मुझे बात ये चालू है. नहीं, लेट मी टॉक नाउ. डॉक्टर राजेश कार्यकर्ता, आई एम गोइंग टू कंडक्ट द नेक्स्ट कॉन्फ्रेंस. सो I made the fees exactly as per. I didn't raise any money, any paisa for that.
आप बढ़ा दीजिए सर.
तो 10% से
आप
raise
बढ़ा
करना
दीजिए.
पड़ेगा मुझे.
See, if you go to any shop, he tells you 2% on credit card. Now, who pays for that 2%? We only pay, na? The shopkeeper doesn't pay. So, see, this is not a new thing that we are starting. Hospital Infection Society already charges it. They charge 20% of the registration fee. So, there are many other societies which are doing this. And anyway, whatever is balance has to be returned to IMM, like Bhubaneswar is giving 5 lakh. They have a kitty left of about 6 lakh something. They are keeping 1.5 lakh for Odisha chapter and the rest they are giving.
We don't have problem in giving the money later on. I need to raise it because I have put it on the website. So I have to raise by 10% now, straight away. So I will do that because I didn't raise the price which this conference had. So I kept the same thing. But now I think I will have to go raise by 10%. So I will change it then.
Open to house for discussion.
10% in any case because that
Open
would
to
be
house,
very difficult for us because Pune is also very. Yeah, this fellow, yes, madam has done already. So one, even yeah, she did it.
So the few lucky people get 10% discount.
Okay then. No, I have no. Even if I raise the money, raise the fees, I'm not going to charge you. Yeah, not.
That's
So
what
she
I
did
said.
it
The
for
few,
first
very few lucky people.
Yeah. So no, I'm not now. No registration now. I will raise it first. Right. So 10% I raise, madam. Thank you. Thank you.
Because we have also conducted the conference, we all know that conferences cannot be done only by the registration. So instead of increasing to the delegate, there are other sources we should focus on that to increase the budget.
Madam, I have one point to just ask.
Yes, ma'am.
Now, we see if 10% registration fees is taken by IMM, then all that expenses done on IMM members should be done by IMM. The conference person shouldn't do that. He should only focus on the conference.
The whole conference is for IMM members only, sir.
No. The governing council or the people who have to be paid, in the sense all arrangement has to be made, then we'll make arrangement for the conference itself. That has to be there. Because if 10% is going to go in the kitty, then that 10% should be used for all other activities. We will be busy with the food and all of the conference members who come there. So that there has to be some way out of it, because this cannot happen. I don't know how much.
That way we will never increase the IMM kitty.
See, the thing is that there is no way. It is a must to do all those things. It is all in gesture. I'm saying you that these are the question of respecting this gesture and all this. I'm just trying to say that you go ahead with your conference with this 10% which is there. Might be you are the first person who will ask money from IMM because of the NMC bill may come in 24.
No, then in this situation, the first thing we'll have to do is we'll have to have a clear-cut SOP of what is to be done. So
that SOP is there, sir.
Everything.
That SOP
so
will.
I would like to have it.
Sir, that
me,
SOP will be given to you because now the GB has approved, for your conference.
Yeah.
the website is usually launched on the valedictory function.
Yeah, I have not launched it yet.
So the issue is that your conference has been approved now. So you will get the SOP. I will mail it to you.
Okay, ठीक.
We have an SOP.
Okay, so but one thing has been made final, 10% raise I'm going to make.
10% raise in registration money is your decision, sir.
Okay, done.
As an organizing chair and secretary,
Okay.
it is not the GBM's decision.
Okay.
The approval is only for that fee which has to be given to IMM.
Okay.
And it is valid from this year itself. So.
Okay, thank you.
So mainly for the organizers, there is always a challenge because there are so many state chapters, and the diagnostic companies generally say that they have to fund a lot of state chapters as well as the national conference. So raising money at conferences is quite a challenge. So anyways, my point which I wanted to ask is there any way that there could be a recording of parallel sessions? Because mostly what happens is students, say out of a bunch of 30 or 40 PGs in the department, only a few are able to attend. And if you have recorded, because you have experts coming and giving these lectures, and for the benefit of the students, if some provision IIMM can make of recording these and putting it on the site, that will be really useful for the
I think these sessions, if the organizers will share the sessions with us, we'll put it up. Otherwise, usually the Bhubaneswar website was active till October. So they
Madam,
can even
all
put it up.
sessions are not recorded.
I can put it up on PG Masterclass. See, they have to provide the recording, ma'am. The organizers. IAMM cannot arrange for recording of the sessions. That is their autonomy.
May I please add that the organizer has a lot of other things also to as an expenditure.
See, even this session is getting recorded. They usually have a photographer and a video recording.
Because ma'am, if video records can be put on the site, that will be very useful.
Exactly. That's what my initial statement was, that the organizer can put a link on their website. Thank you. So the other is to increase.
Ma'am, then all sessions will be recorded. What I was given to understand is all sessions are not recorded. That is the reason I'm putting this forth.
Ma'am, these sessions are not recorded is as per the organizer's decision.
मैडम सबके लिए खर्चा लगता है ना मैम
मैम तो ऑर्गेनाइजर ही करेगा ना
Ma'am, actually ma'am has given a very good suggestion. So when EC can decide or GBM can decide for 10% increase of the fee, why we cannot decide this ki organizer must record and it should be provided to the IMM so that it can be put on the website.
Exactly.
Because if he can send 10,000 rupees of putting in, notice of mic.
There are so many parallel sessions. हम ही नहीं कर पाते हैं दूसरी जगह. No.
Absolutely.
See, generally the recordings are put almost 3 to 4 months after the conference. So those who attend the conference do get the benefit.
But ma'am, पता तो है ना कि आएगी recording.
नहीं ma'am, the thing is, even people who attend the conference cannot attend parallel sessions even if you want to. So this is actually a very important thing for educational purposes. No, these are experts and the type of.
Sorry, can I disturb? 2 o'clock we have a next session here.
I know.
Please, we have a next session at 2 o'clock.
I am at my last slide, ma'am.
Vatal chairing it. Last comment, please.
I can talk 1 minute. Ma'am, there are 3 sessions at 3:15 which I want to attend. I have paid registration for the conference and there are 3 different sessions. I want to attend all 3. So what I can do?
See, even I feel that a lot of parallel sessions should not be there. So, if you look at my next slide, an SOP for MICROCON program we are going to sit and make, where there are no more than 3 sessions. 1 main session and 2 other sessions, and the rest are poster and oral, and all those sessions can go on. But there should not be more than 2 or 3 parallel sessions. This I also felt yesterday because there were a lot of conflicts going on. And the area of interest is usually, if I am interested in bacteriology, virology I can do away with. So that is my decision to make, not for others. So maybe we make an SOP in such a manner that if there is bacteriology at one place, there is parasitology at other place and virology at other place. Maybe then we can sort this issue, or we have only one plenary session and do away with it.
So can I add something regarding the recording? I think it is very essential, first of all. We should not go away with it. The suggestions by other people, there are simultaneous sessions going on, or maybe it can come later. The only thing we can do is, like American Society for Microbiology and many international organizations, they also charge for that.
Charge for this session.
And it comes later, maybe 2-3 months later, and they say that this you can access if you pay this much of amount.
Okay, we'll work out these
So that is
modalities.
another way of making money.
That's a valid suggestion, and we'll work out on this, ma'am.
And they get the online certificate also.
So
you will get the participation certificate, which can be done either.
That's very valid, ma'am. We'll work on this and we'll get back to the house on this. But the other thing is that everybody has to give their consent. So this is for next year's organizers. If you are putting anything, any recording online, even when I write a mail for PG Masterclass, I tell them this will go on live on YouTube streaming and will be going on YouTube. So that I get, if the moment you acknowledge that invite, I know that you've consented to your recording being going live and be available on internet. Many people do not like that also.
Ma'am,
Hanji ma'am, sorry.
So if at all we intend to put recordings on a website, then IIMM website has to be ready for it, first of all, because all the conference websites are temporary websites. And
So
we
they,
can't hold on
ma'am,
for a long
they
time.
keep it for temporary only.
No, but if we really want to treat it as a resource, then you must host it on the IIMM website.
We can't, no domain
Right.
will host it that much of information for
So
such a
that-
long
so
time.
then the recordings really then don't make that much
I
sense.
think
And-
this
and more parallel session is to create more interest in more people. Not everybody can be working in just one field.
this nitty-gritty cannot be discussed in the general body. It can be discussed in the EC and those aspects. And another aspect I was just thinking, when you are saying this recording, it should be available to those who have registered.
Yes.
Well, that's all. That is happening in ECMID and other. So if you are not registered, you cannot have access it. So people will be registering for the conference.
And just a small
So there
suggestion,
is-
as I agree with you, like yesterday, there was a like parallel session with along with the EC. So I missed half of it because I had a lecture
Ma'am,
there
the
and
EC
when
the
the
EC
session got delayed.
I had
right?
requested.
So I missed half of the EC because of that.
The proposal is to increase the life membership to 10,000 from 5,000. And the associate member, we call it an associate member, combining both student and annual member as rupees 1,000, which is valid for one financial year. It is currently 250 and 500 rupees. 250 for student membership and 500 for annual membership. So we thought it's high time that we increase this. So if the house approves, okay, because it's hardly any amount now. This was 2006 amount. So the SOPs, we've already made committees. Dr. Sanjay, myself, we'll take up 2-3 EC members and we'll make these SOPs. Zoom connection, we will require a renewal in February because my WHO project is now finished. So I will require it from the IMM kitty. And we need to work on website. Dr. Manoj has agreed to talk to the website manager to make it more interactive and more lively. Because right now, the website manager takes a lot of time in uploading and all. So he's going to work out the modalities if we can find a better solution to it. So with that, thank you. It's a valedictory mein.
Valedictory. अभी 2 बजे सेशन है अब मैं चेयर
Ma'am, I will now request, ma'am.
अभी क्लोज तो नहीं करना थैंक यू
हाँ नहीं, I think we've
Thank
we're
you
ready to
everybody for your time and your suggestions. And now I declare the GB closed.
Closed.
So all matters discussed accepted.
Thank you, ma'am, and thank you, everybody.
Thank you, Dr. Soul.
It's a humble request. All the esteemed speakers and respected chairpersons, please collect your certificates from the registration counter. Thank you.
Dr. Vimla, we have about 15 minutes for quick lunch. 15 minutes. All उतना ही चाहिए. Nandini.
My presentation is here, right? Laptop is here. Okay, this is.
हाँ 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 चालू रखना है मैं भी रिटायर हो गया चंडीगढ़ में भी तो होने वाली 2016 में हमने किया था चंडीगढ़ में उसके बाद चंडीगढ़ में है नेक्स्ट तो पूना में होगा नहीं नहीं जब आपने वो वहाँ दिया था ना हाँ हाँ कल आपने कोट डाला हुआ था बड़ा सा और थोड़ा सा कमजोर लगे जब आपको वो इंटरव्यू में देखा थोड़ा सा वीडियो अच्छा नहीं नहीं अब यहाँ ही बैठ जाए ये सामने आ रहा है वेट तो बिल्कुल ठीक है वो तो चलो थोड़ा सा रूम पे छुड़े आ गए अच्छा वेरी गुड
तेल चढ़ा के हैं वहीं से खरीदा वहीं से जला आ जाए स्पीकर्स आ गए अच्छा अच्छा नमस्कार तो वी कैन स्टार्ट और वो बुला लेंगे आप बुला लो हाँ हाँ प्लीज स्टार्ट मैं और डॉक्टर वाटर तो कह ही रहे थे इनके वो लोड हो गए हाँ चलो बुलाओ इनकी इंट्रोडक्शन बेटा मैं पढ़ लेती हूँ फटाफट तो आप हमें बुला लो फिर आप ऊपर जा रहे हैं ना हाँ जी वो उनके थोड़ा सा पढ़ तो लें तो पहली बार कुछ
Welcome back, respected delegates, esteemed speakers, and chairpersons. Our next session is on Symposium on One Health Concept in Infectious Diseases. I would request our chairpersons to please come on stage. Professor Aarti Kapil ma'am, President IIM. Our second speaker, Professor Chand Vatal, who is the Chairman, Institute of Clinical Microbiology and Immunology, Sir Gangaram Hospital, New Delhi. He has nearly 120 publications in various national and international journals. He has been awarded with various awards like Hospital Management Asia Award 2002, Dharma Veera Award for Excellence, S. Nandi Award as the best publication of the year. He is the editor-in-chief in IGMM. Sir, please come on stage. I would request our chairpersons to please welcome our speakers. Thank you.
Thank you. Thank you. It's my pleasure to invite our speakers. The first, Dr. Anup Velayudhan. He's a scientist E-Medical at the Indian Council of Medical Research, and his area of work is One Health, Biosafety, Rare Diseases, Epidemiology, Surveillance, and Public Health. And he's basically MBBS from Government Medical College, Cochin, and then MPH from Sri Chitra Tirunelveli Institute of Medical Sciences. I welcome you, sir, Dr. Anup Velayudhan. Thank you.
A very warm good afternoon. First of all, let me start by thanking MICROCON for inviting me here. And the topic given to me is very, very pertinent in the field of today's microbiology and the whole scenario of health. So I myself heard around 3 or 4 talks on One Health from yesterday since I've been here. And it is very, very enriching to hear that One Health has gained traction in the field of public health and in microbiology. So the topic today is One Health concept in infectious diseases. And India started off its journey into G20 saying Vasudhaiva Kudumbakam, that is one world, one family. There cannot be a greater definition for One Health than what India professed through its G20. Let me walk you through the contents. I'd be talking about the journey from zoonosis to One Health, the conceptual adaptations that we have traditionally understood to the postmodern notion of One Health. What is One Health, what is the history of One Health, and what is the One Health quadripartite doing right now. I would also like to inform you of the One Health scenario in India and where we are. I would like to leave with the role of laboratories and the role of microbiologists in One Health. What is the envisaged role that labs and microbiologists can play in One Health in the future? So we know that annual outbreaks have increased by 6 times in the last 3 decades, and 60% of them have come from animals in the last decade. It is recorded that 300 crore people have been affected with 5 crore cumulative human diseases due to zoonotic diseases. It does not affect human only. There is impact on livestock. There is impact on the wildlife as well. The global impact on livestock itself amounts to 25 lakh crore dollars annually, and 20% of livestock production is lost actually due to animal diseases. It also affects exports and food security, and wildlife diversity is affected due to animal deaths, which causes disruptions in the food chain and causes long-term ecological challenges. So traditionally we know, and we have read about zoonosis in our textbook of Park. It is any disease that is an infection that is transmittable from vertebrate animals to humans. It can be bacterial, viral, or parasitic, and may involve unconventional agents. It is spread through direct contact or through food, water, or the environment. And there are over 200 known types of zoonosis, saying that known. We still don't know how many types of zoonosis are yet to come on. Because of the close relationship of animals in agriculture, animals as companions, and the natural environment which we live in together as part of our daily routine, due to disruptions in the production and trade in animal products as food and as milk and dairy products, we are very much exposed to the animal kingdom, much more than what we can envisage. So zoonosis comprises a large percentage of new and ideal diseases in humans, and many existing ones and percentage of newly identified infections are zoonosis. We all know that HIV muted into a human-only strains, and recurring diseases like Ebola, salmonellosis, and even the novel coronavirus pandemic that caused the global pandemic started off as a zoonosis. I've already told you that about 1 billion cases and millions of deaths occur each year from zoonosis. Over 30 new human pathogens have been discovered, 75% of which originated in animals. If you look at the journey of zoonosis, which started from BSEs, bovine spongiform encephalitis, and then the Hendra virus outbreaks were detected in 1995. Nipah came around in the millennial in 2000, and Marburg came in 2000. SARS, which emerged as a global pandemic, also came about in the year 2022. And then H5N1, Ebola, Zika, and then COVID-19. The latest addition to this list being monkeypox, which India had an outbreak, as you know, recently. There is also a history of One Health concept. In 1855, it was Rudolf Virchow who coined the term zoonosis, and another pioneer, Charles Schwab, he coined the term One Medicine in his textbook of Veterinary Medicine and Human Health. From that, there has been a series of changes in the conceptual understanding of human health, One Health, animal health, all blending into One Health eventually. It was in Ireland in the first OHIP annual scientific meeting in Dublin where One Health champions came across, and the animal health extended its arm and hand to other sectors of human health and environmental health. And formally, we had the birth of a One Health consortium. So there is this quadripartite that was in 2008, the Food and Agricultural Organization, which had formerly worked with OAA, the World Organization for Animal Health, and the human health part, of course, WHO. All of them strategically worked for a framework for approaching global health problems. It was in 2011 that FAO put together a strategic action plan for One Health. Strangely, the FAO had to do it because the most losses was economic, and FAO bore the brunt of all the outbreaks coming from zoonosis affecting the meat products and animal products thereof. Again, the FAO, WH, and WHO published a new guideline to approaching zoonotic diseases with a One Health framework in 2019. And in February 2021, there was this One Health approach to prevention of future pandemics. As I said, in 2022, the tripartite annual agreement came across and involved the UNEP, the United Nations Environmental Program, that formed the quadripartite together with the tripartite partners. So One Health is an integrated, unifying approach to balance and optimize the health of people, animals, and the environment. The essence of it is to mobilize multiple sectors, disciplines, and communities to work together and develop new and better ideas to address the root cause and find out sustainable, innovative solutions to common problems affecting all the sectors. The key principles in One Health are interdisciplinary collaboration and holistic approach to problems, prevention and control, and sustainability of solutions, so that whatever you start in one part lives on for other sectors to adopt, other sectors to live on. The need for One Health came across through disease interconnectedness, the environmental impact, as I had earlier mentioned, antimicrobial resistance, as the morning sessions I talked over, and emerging diseases which proved to be a great burden on the human health as well. Of course, food safety, as I had mentioned before, from the FAO and other sectors, proved to be costly in the economic run. So these are the sectors and disciplines involved in One Health: human, animal, and environment. And then for the healthy human, healthy ecosystem, and the healthy collaboration, we need the support of society with an inclusive, equitable, and accessible reach to all sectors, to treatment, and also to wellness. That is why we say that One Health, the core of One Health is in coordination, capacity building for One Health, collaboration between different sectors, and overall communication between all sectors possible. So leading on to spillover events, which gather a lot of noise. In fact, that whatever species are there in the animals or the environment, how much of them can actually spill over to human events. So this is a 2018 operational framework by the World Bank that actually focuses on strengthening the animal, human, environmental, public health system at their interface. So these are the number of cases. In the y-axis, it's plotted how many cases of wild animals or humans or even insects or vectors happen, and what is the timeline. So it was discovered that spillovers occur first to the wildlife sector, then to the peri-domestic area or to the domestic animals from then ultimately it reaches the human beings, where there is human amplification going on. And this is where we sound the alarm and we say we have an outbreak, we have a problem that is in the human sector. This is where we need to take action. But the below graph shows you there are time or the delay of around 21 to 28 days where before this graph actually even reaches the human beings. You have a time of around 28 days where you can actually forecast the readiness. You can actually detect the outbreak if you look at the animal sector, the environment sector, and actually have control operations set up for a rapid response even before it reaches the human sectors. That is the beauty of recognizing animal outbreaks or animal diseases in the animal sector. So One Health today is a paradigm, if I may be allowed to call it, or it's actually an umbrella term comprising of environmental health, ecology, veterinary medicine, public health, human health, molecular biology. So there are zoonotic infections that we need to keep an eye open for, and then there is comparative or translational medicine onto which the gains of One Health paradigm can be applied for prevention and control of diseases. So the latest fact on One Health is this One Health Joint Action Plan that was put forward by the Quadrant for the years 2022 to 2026. So it is actually built on 6 interdependent action tracks. Action track 1 is to enhance the One Health capacities within each of the sectors, both human, animal, and environment, to strengthen the health system or part of the response. Action track 2, which talks about reducing the risks from emerging and re-emerging zoonotic epidemics and pandemics. And then you have an action track 3, which talks about controlling and eliminating zoonotic, neglected tropical and vector-borne diseases. And in action track 4, it talks about strengthening the assessment, management, and communication of food safety risks. And an action track 5 that talks about AMR. And an action track 6, which talks about integration of One Health or the extension of it into the environment itself. Coming to what has been going on in India, several ministries have had their own version or own understanding of One Health depending on where they see One Health from. So most of the times it is said that where we stand on things depends on where we sit. So each of the sectors looked at One Health with their own particular perspective, and there are always been work in One Health among the human sector, among the various ministries, but unfortunately they're all siloed without talking to each other. One Health in India today is a paradigm of togetherness between various ministries, as I would elucidate. So there was this Prime Minister Science and Technology Advisory Council that endorsed the creation of National One Health Mission in July 7, 2022. The PM's Tech actually recommended creation of this One Health Mission to serve, to coordinate, to support, and integrate all the existing activities of One Health across the country and to fill gaps wherever appropriate. So this is the slide graph under the PSA. These are the ministries that are serving in the One Health mission. We have the state government, Indian Council of Agricultural Research, NDMA, the National Center for Disease Control, the Ministry of Health and Family Welfare, the Ministry of Environment, Forest and Climate Change, ICMR, Department of Animal Husbandry and Dairying, the Department of Pharmaceuticals, the Department of Biotechnology, Department of Science and Technology, even the DRDO, which makes to be the vigilant front, CSIR and the Ministry of Ayush, which make for the government stakeholders. So the governance structure comprises Apex steering committees, which is composed of secretaries and director generals. It is chaired by the PSA, the principal scientific advisor to the government of India. And then there is this One Health Action Group, which comprises of nominated members of all the relevant ministries and departments. And then we have work stream specific committees and state level pilots going on currently. So this is the main agenda and the action players, together with the NGOs, the private sector, multilateral agencies, academic institutions, G20 and other forums, and of course public engagement, which is a major part of community integration into the forum. So this is what comprises of the One Health infrastructure in our country presently. So first and foremost, it is vision that there will be an integration of surveillance across sector. This is the cornerstone of public health activity in the One Health mission. We would have integration of clinical data along with disease surveillance program. The human surveillance programs such as IDSP, ABMP would be linked to the livestock, National Digital Livestock Mission, and the wildlife surveillance program, the National Referral Center for Wildlife, that is being built upon right now. All of these data from all these 3 surveillance programs would be going together as part of the disease surveillance programs. And we would also have environmental and sentinel sites set up between NCDC and ICMR so that you have an overall surveillance going on currently at the airport, sewage, vector, the animal trade, or the milk or dairy products being formed. It is also envisaged that you would collect non-traditional data from digital print media, such as media surveillance going on. So all of these would feed into the lab networks we have in our country, the BSL-4, BSL-3s, the community networks of health integrated systems. And there would be complete integration of these platforms which would talk with each other. So again, the sentinel sites are again an important point. We have methodologies for environmental surveillance that would be set up. There are sampling methodologies being set up, lab assays, and pilots across human, livestock, and wildlife sectors are being envisaged as we talk. So, places where you envisage a higher degree of animal-human interaction with the environment will be picked up and looked upon for surveillance, such as zoos, protected areas, abattoirs or slaughterhouses, animal fairs, milk factories, and other vector-borne disease conditions which can lead on to, and then the sewage surveillance and surveillance at airports, which are port of entry for many travelers and also for diseases that are being put under surveillance. So this is the envisaged National Institute of One Health, NIOH, that would come up in Nagpur, that would serve as the institutional anchor for R&D activities of the One Health mission. This was the Honorable Prime Minister of India laid the foundation stone for the institute on December 11th, 2022. And it was decided that all the R&D efforts across all the ministries would be housed at this center. So this is I would say, a post-modern paradigm where all the representative ministries and scientists and even some small labs will be housed across in a single institute, and they would work shoulder to shoulder together. Can I help with the slides? Yeah. So these are the objectives of the R&D activities of the One Health mission. The mission aims to undertake integrated and holistic R&D across human health, plant environment for early detection of epidemics, pandemics following a One Health approach. It aims to establish framework for integrated disease surveillance across human, animals, and environment sectors. There is this plan to develop a roadmap for targeted R&D for fast-tracking medical countermeasures like vaccines, therapeutics, diagnostics devices, and genomic tools for pandemic preparedness. And overall, the idea is to coordinate research, data, and information systems for current and emerging disease for evidence-based decision-making. It is also planned to create a cadre of trained professionals for R&D, joint outbreak response, integrated surveillance, and analytics across sectors. Of course, it goes without saying we need international partnerships and to foster linkages with global efforts for pandemic preparedness, such as the Quadripartite, the G20, the CEPI, and other organizations multilaterally. Let me now come to the role of labs in One Health. What, as lab scientists and laboratoricians, can be the role of people working in One Health? So traditionally, we have been working in diagnostic medicine. We have received samples, we have characterized them, and we have seen what disease does this patient probably have. But to move a step ahead or to move out of our labs, understanding the genetic makeup and behavior of pathogens to develop effective interventions can be one step where the One Health paradigm would set in. We could play a great role in disease surveillance and monitoring, where the samples from human, animals, and environment can be detected, monitored, and you can have an early detection of emerging infections using the next generation sequencing that facilitates a holistic and integrated approach to health, One Health across all sectors. Again, we are also basic scientists working in the domain of microbiology. So an integration of zoonotic disease research can be a part of our endeavors while studying zoonotic diseases, developing the understanding of dynamics of these diseases for prevention and control strategies, and to characterize emerging and re-emerging infectious diseases that would require public and animal health professionals to work closely with each other. Understanding of this disease pathogenesis must be done using comparative pathology and animal models so that efficacious diagnostic methods for zoonotic pathogens would be more robust if targeted towards both animals and human beings. And the AMR resistance studies, One Health labs, they investigate the emergence and spread of AMR and the use of antibiotics in humans as well as animals, as well as environmental factors contributing to AMR. Another rich area of study, very nascent in India, is in the area of biosafety and biosecurity. As labs, we are the custodians of rich information, but dangerous ones too. We need to hold them close to our heart, but keep it apart so that we ourselves don't get infected through these pathogens, nor we allow it to spread or to be released into the environment. As microbiologists and as lab professionals, we are also part of the healthcare system. This can involve developing SOPs for safe and secure diagnostic sample processing, collection, handling, transport, and also the disposal to finish the cycle of biosafety and biosecurity. And we must also be brave and robust enough to report outbreaks of zoonotic and unknown infectious diseases in humans and animals. And we should alert biomedical professionals and a potential outbreak of new zoonotic agents or potential emerging pathogen is being seen by us. This will lead to comprehensive surveillance programs that help to minimize the spread. That means fewer cases and will minimize sample collection and processing. There is a One Health revolution for pandemic preparedness that is on Oxford has taken a leap to actually bridge the differences between human, animal, and environmental health. In COVID-19 pandemic, you have seen how this testing has been scaled up. We developed indigenous test kits and whole genomic sequencing forms. We are ready with days such as vaccine library and therapeutic library. So with the advent of animal health and environmental health, aim to further capacity include GPS for mapping the hotspot, which integrates geographic information system, artificial intelligence forecast outbreaks through mathematical modeling, genomic sequencing at the field, going to the field and collecting samples and having a processing done at the field and providing outlets. Some of you would be aware of the mobile BSL platforms and the also there. A revolution for pandemic where nano-based technology, PCR-based diagnostic, genomic sequencing, AA-based diagnostic, sensor-based technology, and modern imaging comes into play. So the role of multi-sectoral One Health, the government is one part of the whole conundrum of One Health. We have the academia, such as yourself, all of you going into the field tomorrow to practice microbiology. We have the governance system, which are policy regulations and leadership and response team, industry, which makes vaccines and diagnostic kits, the ecological and the industrial platforms working with NGOs for and well-being of the country, and the whole map of risk vulnerabilities, the causes and impact of diseases, which actually leads to integrative management and communication. That is the One Health paradigm where it stands off today. So this is the role what a microbiologist can play in One Health. This is a case study of One Health. In 2008, 97 people actually became ill, and one person had Guillain-Barré syndrome. This was a source of an Alaskan outbreak of Campylobacter infection that was traced to the consumption of peas. It was determined that the peas became contaminated where they were in the field and not from packaging. And further tracing or back tracing of food item shows that the field in the flight path of sandhill cranes that left there dropping on the crop, leading to contaminated product. So isolating the causative organism was a small part of the process, but understanding that isolate could be part of the intestinal flora of migratory birds helped actually solve the problem and prevent the next problem from arising. This is something that I wanted to leave you with, implications of the health paradigm. This is an article written by J. Michael, communicating, working with animals, veterinarians, our counterparts in other sectors. That actually helps the One Health approach to grow, to enrich our own sectors of human health. Thank you, and One Health involves reminding you that working together is key to health, and that's forward. Thank you.
Thank you so much, Dr. Anu. And thank you for introducing to us to this One Health mission and how our preparedness for pandemic. And now I'll request Dr. Vatal to invite our next speaker. Maybe chair. Have one or two questions. Thank you.
Can I invite Dr. Vaidya KR to the podium for his presentation? Vidya. And she is MD Community Medicine and has extensively worked on Kesanur forest disease and rabies in her career as well. And she has received various awards and has worked on Zika virus as well and published internationally as well as in the local journals. In the interest of the time, I would request her if she could spare a few minutes and try and truncate her presentation. Thank you very much.
Thank you, sir. Thank you, sir. Good afternoon. And I would like to thank organizers for inviting me as a speaker for this wonderful conference. Actually, I was part of the Nipah outbreak in 2019 at Ernakulam. I was the district surveillance officer, and I was the state nodal officer for that who was sent by the state government of Kerala for 2019 Nipah outbreak in Calicut. So before going into the One Health approach that we did in Nipah outbreak in Kerala, I would like to speak few words on what is Nipah and what are the control measures we are supposed to do, and how did we control it in 2018 onwards, like approach. So since all of you are microbiologists, most of you will be knowing about the can you please change the slide?
The screen is not moving probably. Can you help?
Excuse me? Yeah. And it's called as barking pig syndrome, and many of you might be knowing everything about, all of you will be knowing everything about the Nipah, but still I'll speak few words on Nipah before going into the One Health approach. It's also called as syndrome and also porcine respiratory and encephalitis syndrome or porcine. It was first outbreak happened in 1998 in Malaysia, in Nipah village, and the virus was identified in 1999. It causes human febrile encephalitis and it has a very high mortality. Since 2001, and the outbreak has happened in Bangladesh and also in India, Siliguri, India. And in Singapore in 1999, there was another outbreak in abattoir workers. The pigs were imported from Malaysia. So this is the area where outbreak had happened. And the purple dots, it denotes the Pteropus species. And this is the green is the flight range of, or the where the Pteropus species are found. And orange countries are where the outbreaks have occurred. And these blue dots are where the Hendra virus outbreaks had occurred in the world. And in Kerala, the first outbreak happened in 2018. We had 18 confirmed cases with 4 probable cases, and only 2 survived. Apart from the index case, we had 4 probable cases. Then second outbreak happened in Ernakulam with 1 case and no death. And third outbreak happened in Calicut in September 2021 with 1 patient. And fourth outbreak happened in recently in 2023 in September with 6 cases and 2 deaths. As you can see, India also, India is a area prone for Nipah with outbreaks happening in Siliguri and also in Kerala. And the agent is a very highly virulent zoonotic pathogen, and it is an RNA virus, Paramyxoviridae family with from the genus Henipavirus. It's similar to Hendra virus. And there are 2 NIV clades, that is B genotype that is found in Bangladesh and M genotype in Malaysia. And the Kerala genotype has 85.14% similarity to M genotype and 96.15% similarity with B genotype. And the reservoir is large fruit bats, that is Pteropus species, intermediate hosts are pigs, then horses, monkeys, and the contaminated fruit harbors virus for few hours. And Kerala and in northeastern states of India, we have identified throat swab positive bats. And and it exhibits a seasonality, that is in December and May, but we had breakthrough infection that has happened in September 2023, and the incubation period is 4 to 21 days. And this is the Nipah virus structure. It's a single-stranded RNA virus with 18,246 nucleotides in length. And the mode of transmission is from bats through fruits, that is contaminated by bat secretions, that is urine, saliva, reproductive fluids, or by consumption of raw date palm sap. That had happened in Bangladesh. And this from pigs that is infected by consumption of these contaminated fruits, that pigs become infective, and because of contact with these pig secretions, human beings also became infected. That has happened in Malaysia and Singapore. And in Philippines, there was an outbreak in 2014, and that was through infected horses. And there was human-to-human transmission as that had occurred in Kerala. Kerala, it was mostly human transmission. But how did the primary case got the illness, that we are yet to identify. We couldn't identify in all these outbreaks, but the throat swabs and the secretions were positive from bats. And the important clinical clue is there is clustering of symptomatic cases, mostly adults, that is among close contacts and households. And this is how we diagnose the Nipah case. A suspect case is that is a person from an area or locality that is affected by Nipah virus outbreak, and who has high fever, altered sensorium, with seizure, with or without seizure, then also with headache. Then there is also a clinical history of acute fever with cough or shortness of breath. This had happened in 2018 outbreak. And 2018 outbreak, the symptoms were mostly respiratory. That is why we had very high number of cases and very high number of deaths. In probable Nipah cases, any suspect case that is living in the same village where Nipah virus had occurred, case had occurred, or a suspect case had occurred, and who had lived during the epidemic period, and who died before complete diagnostic specimens could be collected. Or a suspected case, patients who came in direct contact with confirmed case in a hospital setting during the outbreak period, and who died before complete diagnosis was obtained. And a confirmed Nipah cases, obviously there is a lab confirmation of Nipah virus that is identified through RT-PCR from throat swab, urine, serum, or CSF. And also we need to identify, we need to isolate Nipah virus from swab, urine, serum, or CSF. And these are the definitions of a contact. And actually, anyone who has come in contact with a suspected or confirmed case, either in a hospital setting or is epidemiologically linked from the same village, and who had come in contact with the dead body, and who had performed the ritualistic method for the dead body, and who had handled the linen, that any formites that is handled by the suspect or the confirmed case, we call them as a contact. And we need to follow up these contacts for double the incubation period, that is 42 days. That is what we had done in all the Nipah outbreaks in Kerala, and that it should be done in a appropriate care facility. And these are the main clinical features, that is, patient might have fever, fatigue, muscle pain, headache, vomiting, altered mental status, convulsion, cough, respiratory distress, diarrhea, etc. And also there will be a syndromic presentation of ARDS, myocarditis, and encephalitis. And any patient with fever and also will have an epidemiological linkage with a history or contact, and they all should be tested for NIV infection. And the case fatality rate is 40 to 75 and may range up to 100%. And these are the main investigations that was done in Kerala, and that is being advised. RT-PCR for viral RNA, anti-NIV IgM, IgG by ELISA. Then we need to do universal standard droplet and biocontaminant precautions, and also adequate biosafety precautions should be adopted. And this is the sample collection we did, and it should be done only after admission into an isolation facility, and ensuring that the staff member does all the infection control practice. And during sample collection, we need to observe universal precautions, and also we need to wash hands before and after taking specimens. And these are the recommended samples, that's throat swab in viral transport medium, urine sample, that is 10 ml in universal sterile container, blood in red vacutainer,
CSF in sterile container. And we need to document all the clinical features in an appropriate format. And the transportation should be done in appropriate procedure, good quality Ziploc bags, and it should be placed in another Ziploc bag, and the carrier should be in hard container sealed with impermeable tape or plaster, and the case sheets with complete information should be placed in plastic bag, and it should be pasted outside the container. And we send the sample, initial samples we send to, as you might be knowing, in 2018 the first patient was in a private hospital, and we collected that sample and we had sent it to NIV Pune, and we had confirmed it. And now we have, for the 2023 outbreak, we did send the samples to NIV Pune. Then NIV Alapura also we had sent, and we had the NIV field station, that is mobile labs supported by the NIV Pune at Calicut. And the treatment, I will not read out everything. And obviously the patient should be isolated in an isolation facility, and all times PPE should be used by the treating health personnel, hand washing, oxygen facility, all these things. And the treatment must be with ribavirin monoclonal antibodies. For the 2018 outbreak and all these outbreaks, we had purchased monoclonal antibodies from Australia, and unfortunately we needn't have to use it. And so by 2023 outbreak, that expiry had happened for that monoclonal antibodies. And fortunately, we need not have to use those monoclonal antibodies in 2023 outbreaks. Then another one is remdesivir, then favipiravir, and we can give post-exposure prophylaxis also. And about the disease in animals, it is highly contagious. It may be asymptomatic. There will be acute fever, severe respiratory disease, and also there will be a harsh cough. That is why we call it as barking pig syndrome. And there will be neurological changes, but there will be low mortality in animals. In dogs, dogs are also one intermediate host. It produces distemper-like signs, fever and respiratory distress, ocular and nasal discharge. In cat, there will be fever and depression, severe respiratory signs. In horses, there will be encephalitis. And these are the differential diagnoses for swine. That is classical swine fever, that porcine respiratory and reproductive syndrome, pseudorabies, swine enzootic and pneumonia, porcine pneumonia. And diagnosis tests, we can do ELISA, immunochemistry, and RT-PCR and viral isolation. And this is the chain of transmission, as we all know, from the bats to the intermediate host. And from the intermediate host, it will have, I would say we are one incidental host. It is either through the bat secretions, that is at the saliva, then it's urine, feces, then reproductive fluids, and from the bats, then bat contaminated fruits, from pigs while handling the pigs, all the secretions from the pigs, horses, all those things. We also become infected, and we get through droplet infection. And this is the transmission cycle. From the bats, it happened in Malaysia. It happened through contaminated fruits that was grown outside this piggeries, and that was given to the pigs, and pigs got infected. And in India and Bangladesh, from the bats, we got it through the contaminated date palm sap, and in Philippines, the human infection happened through horses. So how do we prevent further events? We have to strengthen ongoing surveillance, then sampling of reservoir species, then rapid detection systems we need to have, upgradation of diagnostic facilities we need to have, restoration and conservation of habitats. Usually what happens is in Kerala we could identify many roosters and all the roosters are near the densely populated area because because we have destroyed almost all their natural habitats. So they are very near to the human habitat. Then enhanced interpersonal communication measures we need to do in hospital settings, especially in observing infection control, and there should be a proactive One Health action plan. And why do we need One Health approach to tackle Nipah? Actually, in Kerala, for all the zoonotic disease and for all the vector-borne diseases, whenever there is an outbreak happens, we call immediately an intersectoral meeting. That is a rudimentary form of One Health approach. So immediately we call either the district intersectoral, state intersectoral, district intersectoral, then even the panchayat intersectoral meeting we call. In those meetings, there is an attendance of LSG members, that is local self-government, then animal husbandry, forest, and depending on the illness, we will call all the needy persons from other departments. So this has been happening in all, in all the outbreaks in Kerala, and but how did this became actually useful and structured? It happened during the Nipah outbreak. So in Nipah, actually it's not only the people, the livestock also becomes infected. And this One Health approach, it involves collaboration, coordination, communication, as mentioned by Dr. Anup. And this current millennium, we have seen many zoonotic diseases, especially the recent one, which that is the COVID outbreak. It has a zoonotic component, as we all know, and it builds existing capacities, but it brings all the other disciplines together, disciplines, sectors together to provide broader health benefits. It promotes science-based decision-making. It reduces unnecessary duplication, because in one single sitting itself, with all the necessary stakeholders, we can discuss and we can come to a decision, and we can implement an action. We can prepare an action plan and we can implement an action plan. And why does this disease like Nipah, COVID, and etc. emerge? It's because of climate change. Then there is population pressure, deforestation, and also international travel. As we all know, when in 2019, when the first COVID outbreak happened in Wuhan in December, and the first case in Kerala, first case in India, and also first case in South, other than Wuhan, outside China, it occurred in Kerala because of the international travel only. Like once the outbreak happened in Wuhan, all the colleges, because a lot of students from Kerala, they study MBBS in Wuhan universities. And so once the COVID outbreak happened, all the universities were closed, and there was an influx of students from Wuhan to Kerala. And it was the first case was an MBBS student who had come back from Wuhan, and that person was from Thrissur, and luckily we could identify it, and we admitted that person. And after that, in 2 months after that, in March, again there was another spurt of COVID cases. That were those people had come back from Italy. So because we have a lot of international travel, and we celebrate One Health Day on November 3rd. So it's as I mentioned earlier, it is an intermediate, multifaceted problem, and the intermediate hosts are pigs, horses, and monkeys. And bat is the source, and man becomes an incidental host. And there are a lot of factors affecting these, and like intrinsic factors in bats, like pregnancy, because when there is a birthing period, there will be a lot of secretions that will be falling from, a lot of secretions in the ground from the roosters. And if any man or any animal who comes in contact with these birthing secretions, that they become infected. And because of the agricultural practice, like many of the roosters have been destroyed, and so they come near to the human habitat. And there is, of course, there is trade, as we know, because there is a trade of in Wuhan, as we all know, exotic animals. Consumption of exotic animals, that have become a part of tourism, because people go to these Southeast Asian countries or any exotic countries to have these exotic food, especially bat. So this becomes, and the cultural practices, and then there is urbanization, as I mentioned, and there is a lot of deforestation, and so these are all interlinked, and so hence Nipah becomes a multifaceted problem. And these are the strategies for One Health implementation. I think this has been mentioned by Dr. Anup. So how did we do in all our previous outbreaks? We had international organizations like WHO, then OIE, that is Animal Husbandry's World Organization, then FAO, Food and Agriculture Organization. They provided top-level leadership on global health matters, and of course they had supported Kerala in our Nipah outbreak, especially WHO had supported Nipah in our outbreak. then central and state ministries. And as you all know, because once the outbreak was reported, a lot of our ministry officials had come down to Kerala, and also NIV Pune, then ICMR Delhi, NCDC, all these our central government organizations had come down to Kerala to support us in Nipah outbreak. And they provided us with the insight on how to control it. They supported us in preparing the guidelines and also issuing advisories, etc. And the central government had issued an advisory, and we had issued advisory based on that particular scenario in that particular district. And the district administration, they were the nodal person in that. Is district collector was the nodal person in that Nipah outbreak in Calicut and all Ernakulam. And they also supported in cyber investigation for online fake content, because as you might have read it, in 2018 when the Nipah outbreak happened in Calicut, it was in Perambra Panchayat in Calicut, the whole Calicut district had come to a standstill, because there was a panic. Everyone is actually scared to venture out because of the deaths. Actually, a lot of deaths had happened. And a lot of fake news had been coming out from the district and from around Kerala. So the district administration had helped in cyber investigation, and they also maintained law and order, because for the first 21 days, there was a curfew in that Perambra Panchayat, and also the travel in and out of that panchayat was restricted, and also in Calicut district was restricted. Even people were afraid to venture to Calicut from other districts and from other states also. And the district administration helped in Nipah control, by putting up the Nipah control center. And as I mentioned earlier, central authorities, that's NCDC and NIV Pune, they gave us technical guidelines, provided health and safety advisory, and also situation monitoring, and also they supported us with the lab facilities. And the health department and Kerala Health Ministry, actually there was a strong support from the government of Kerala. Actually, we still, in 2023 outbreak also, that guest house in Calicut, it had served as a nodal control center for Nipah control. And all the ministers, 3 ministers, that is our health minister and 2 ministers from Calicut district, they had stayed at the government guest house for the entire 21 days. Our health minister for at least 14 days, I think. And other 2 ministers, they were from Calicut itself. They stayed in that government guest house for 21 days, and they had controlled our activities with the health department and also the public. So it was very easier for us, because everyone was sitting around a table, and everyone was discussing, and we could issue up to date, time to time advisories regarding Nipah control. And that also reduced panic and also reduced a lot of fake news. And they played a prominent role for resource tracking each human case. And especially in 2018, we could identify that we identified the primary case, but the patient died before we could take the samples. But the index case had consulted Calicut Medical College, and actually that person had gone to all the departments, like radiology department, lab, etc. And he was in contact with so many people, and we couldn't identify who the index case was. So with the help of the CCTV camera, we identified. At that time the patient was in lab. At that time patient was in that radiology. We could identify who the people were sitting around him, who were the health personnel, and so we could add them all in our contact list. And they supported us with the patient care and treatment, personal protective measures, Nipah guidelines, public awareness, and contact tracing. So as I said, in 2018, we had purchased monoclonal antibodies from Australia, and that was because the whole ministry was in that Calicut itself. So on a war footing, we could purchase from Australia. Actually, that time it was in it was in trial mode, and that monoclonal antibodies. So, but we could purchase it, and we could fly down from Australia in to Kerala. So even though all the activities were happened in all these years under, it was a One Health activity itself, but the whole, actually the program was launched in Kerala in 2022. But together, concerted activities had happened in all 2018, 19, 21 and 23. And I am not going into these details because Dr. Anup had mentioned all this. But especially we should remember one thing. In One Health means there is a coordination, then there is a communication and collaboration. That is from people who protect human, animal and environmental health and other partners. And that is why we are doing this, is to achieve the best health outcomes for people, animals, plant and our environment. So in One Health, the human health, the animal health and the environment all are interlinked and all are affected by various factors. Like I'm not going again into this. In Kerala, in One Health, we have thrust areas and for One Health, especially the zoonotic diseases. Then antimicrobial resistance also comes under One Health in Kerala, and there is food safety and security. Then we include neglected tropical diseases, including vector-borne diseases. And then there is laboratory services, and also environmental health also comes under this. Then other health threats, that is any other health threat that is shared by people, animals, plants and environment. And this is the GEO that is issued by Government of Kerala in 2022. And that is the first sitting, that is first state level meeting was conducted on December 10, 2021, and the program was launched on May 22nd, 2022. And here in this, this GEO clearly states that what is the significance of starting this One Health program and who are the stakeholders of this One Health program, what are the various committees that happen, that comes under One Health program. And there is a state nodal officer for that, and there is also district nodal officer. That is we have a program, as many of you might be knowing, we have a program that is prestigious program by Government of Kerala that is called as Ardram program. So this One Health comes under the Ardram program. So the Ardram nodal officer is also a One Health nodal officer, but he supports, he or she, they support the district surveillance officer in conducting the One Health program. And the need is, why did we start the One Health program? The need is, we have a very high population density, as you all know, and we have a very high aging population, and there is a demographic transition. Because the number of youth, that is people in the reproductive age group, is reducing, and we have, we have a low infant mortality rate, then low TFR, that is fertility rate also. So hence there is a change in the demographics, and there is a lot of international travel, and there is population mobility is there, and we have a large forest cover. Initially the program was launched in 4 Pamba Basin districts, that is along the Pamba river, that is in Alapi, Kottayam, Idukki and Pathanamthitta. Actually there's those who know about Sabrimala, that the river in Sabrimala is Pamba river. So all the districts that come near along the river is the Pamba Basin districts. And we will be implementing the program in other 10 districts soon. And the approach is, we need to have community surveillance of unusual events that could trigger zoonotic diseases. And there will be an early detection of suspected zoonotic disease outbreaks. Then there is effective community-based participatory interventions to reduce the risk of risk factors to prevent and contain the spread of zoonotic diseases. And we also have a role in this One Health program, also have a role in epidemics and in disease control. Like there are emerging infectious disease that is in wildlife, then in domestic animals, humans and also, and these all have many factors that is linked to all these diseases. And as I mentioned earlier, our One Health program also includes antimicrobial resistance. And we all know there are a lot of pharmaceutical companies and lot of unnecessary prescription of pharmaceuticals, and actually yesterday when I came and I went to purchase one medicine. I couldn't find any medical shop, maybe because I don't know the place, I don't know. I couldn't find any medical shop in and around our hotel. But in Kerala, it's not like that. You can find every, 1 kilometer, you will find at least nearly 5 to 10 medical shops. So there is indiscriminatory usage of medicines in Kerala, that I can assure you. And also there is use of antibiotics in farms, slaughterhouses. And then there is, we purchase a lot of medicines and we don't, once the symptoms subside, we don't use it, we don't complete the course actually. And we put antimicrobials in for the treatment of animal diseases and also disease prevention. Also, growth promotion also we provide. So this also causes antimicrobial resistance in humans.
Dr. Vidya, could you kindly
conclude? Okay, it's not slide is not moving. So then antibiotic literate Kerala campaign, there is the healthcare workers, civil society, students and teachers, farmers, pharmacists, they all come together for this antibiotic literate Kerala campaign. And this is the brochure we have issued for the public on what they are supposed to do, like when they, how long they have to take antibiotics, what they are supposed to do, like that. So this One Health program, it comes under Rebuild Kerala initiative. The first state level meeting was held on December 10, 2021. And this is supported by International Bank for Reconstruction and Development, then Asian Infrastructure Bank, Infrastructure Investment Bank, then Asian Bank. And there is a disbursement, that funding is by these banks, and there is a disbursement link indicator called as 6. And that indicator is capacity to track and respond to zoonotic disease outbreaks of human importance in a timely manner. And we should do that within 5 years, that is from 2022 to 2021. And in baseline, there is no formal district One Health program. And in intermediary, the Department of Health and Family Welfare, they have operationalized district level One Health coordination system platform with trained and certified staff in all these 4 districts. Then we have trained 250,000 local governments, that is like LSGs and also people in the public. Then Kudumbashri members are also on the One Health program. And we have already undertaken joint disease outbreak investigations and inspections. Then 150 local self-governments are implementing community-based One Health surveillance in Pamba Basin districts. And the end target is we have identified and controlled at least one zoonotic disease outbreak of human importance in Pamba Basin districts. And these are the departments involved: health, panchayats, urban affairs, animal husbandry, fisheries, agriculture, forest and wildlife, food safety, and other departments, any other departments. So the activities at the district level is, we have to ensure people's participation. Then entry-level activities should be explained on the concept of One Health. Then there should be a training plan, and district and sub-district level resource persons will have to be identified, and also plan block level meetings, and also decide a plan for program launch activities at LSGs. And we have conducted meeting and drafting, capacity building and all these things, and we have provided innovative IEC materials, and also we had a consultation and planning meeting with KILA officials, that is Kerala Institute of Local Administration. And this is the program management is by State Health Resource and Training Center, then KILA, and KILA has submitted the training needs analysis, and also module is under preparation. Then interdepartmental heads meeting was organized, and they have decided to set up OH committees, and government has issued orders. Then there's space has been allocated at SHSRC for the functioning of One Health program. And there is a discussion with Digital University for IT-related initiatives.
Madam, could you kindly conclude?
Yes, sir. And finally, we have started Kerala One Health Center for Nipah Research. Recently, when we declared the 2023 outbreak as over in November. So this was inaugurated by our Honorable Head Minister, and this center will analyze the data collected through community surveillance, and other departments also will be part of this One Health Center for Nipah research. So this is what I would like to say about the One Health program that we have initiated in Kerala, and also the One Health activities that has been done as part of Nipah research. Thank you.
Thank you, Dr. Vidya.
Thank
Wonderful
you so much.
presentation.
Yeah,
We
thank
know
you
that
so
Kerala State is doing excellent job as
Thank
far
you,
as
sir.
zoonotic illnesses are concerned and picking up these cases so well, knowing it from the horse's mouth. I would always wonder how well are they doing and what else are they doing. And thanks for giving the details. I will hand over the mic to my senior colleague over here. And I think we do not have any time. And if the people in the audience have some questions for both of them, I would encourage that they interact with them during the tea time when it follows. Thank you very much, both of you.
Thank you, sir.
for
Thank you, ma'am.
excellent
And thank you,
presentation.
audience
Excellent
for
presentations.
kind listening. Thank you so much.
Thank you so much.
We humbly request our speakers to please felicitate our chairperson to felicitate our speakers. Sorry. Thank you, ma'am. Thank you, sir.
For our next session of the day, we have the topic accreditation of microbiology laboratories. For this, I would like to invite our chairpersons for the day, Dr. Rohit Chawla, sir. Sir is professor in Maulana Azad Medical College, New Delhi. Sir has received the Distinguished Award of President National Board of Examination